de poursuivre la négociation entre les différents secteurs. Et pour cela, au niveau de la CEDEAO, nous pensons qu'il faut renforcer la collaboration entre l'OAS et le commissariat chargé de l'agriculture, parce que ce commissariat aussi travaille avec ces ministères. Et il faut que les deux renforcent leur collaboration pour continuer les plaidoyers sur cette question de l'approche une seule santé. Et bien sûr, il faut continuer à renforcer les capacités, comme je l'ai dit, parce que s'il n'y a pas de capacité, même si vous êtes d'accord pour faire du travail, vous n'avez rien à échanger. Donc, il faut continuer cela. Voilà à peu près, comme on doit aller vite, comment nous voyons ce que la CEDEAO va faire, va continuer à faire. Et la deuxième question, comment les pays du REDIC ont-ils œuvré pour suivre les améliorations des systèmes d'alerte ou des lacunes persistent, sur quoi les pays HEPS travaillent? Je pense que, comme je l'ai dit, avec les plans d'action nationaux de sécurité sanitaire, les gaps sont identifiés. Il faut simplement continuer à travailler, à adresser ces gaps. Je pense que c'est dans cette perspective que s'inscrivent les pays. Je voulais dire, il ne faut pas seulement attendre des projets, mais je pense, même sur les ressources nationales, il faut que ces ressources soient utilisées pour adresser ces gaps. Et dans ça, bien sûr, les secteurs ne sont pas au même niveau. Les HEPS, une de ses priorités, c'est par exemple le renforcement des services vétérinaires. C'est pour ça que l'un des principaux partenaires techniques cette fois-ci, c'est l'Organisation mondiale de la santé animale. Donc, il faut vraiment renforcer les capacités des services vétérinaires, certainement des autres, pour qu'ils soient en mesure de jouer leur contribution. Je pense que c'est bon, essentiellement ça que j'allais dire. Sinon, il faut continuer à travailler sur les différents domaines que le REDIC a fait. Puisque le REDIC, c'est 2016, 2024, 2023. À l'échelle de 6-7 ans, je ne crois pas qu'on soit en mesure de régler tous ces problèmes. C'est déjà bien. Ils ont été identifiés. Le travail a commencé à être fait de différents problèmes. Il faut continuer simplement à travailler pour adresser les différents. Voilà à peu près ce que je peux dire.
Thank you very much, Mr. Sani. Thank you for your contribution. I won't be able to summarize it, but I guess every one of us read clearly how we have been able to do sustainability and then also how the project will be built in, the gaps will be built into the HEPS project. What we are going to do now is to quickly have the question and answer sessions. We have been informed that the hall will be used immediately at 12 noon. We're hoping to transition into the break before, but we have been told that there won't be break. So just keep your question brief, concise, and to the point. Do we have questions in the hall? Please just raise up your hand so I can recognize you. Thank you. Number one, please come. Can you just give the mic to him so that I can ask his question? And then I urge also those to answer the questions. If the questions are directed to you, please be very precise. There's another hand over there. There's another hand over there. So let's take those three. Number one, sir at the back, you're number two. Then someone here, you're number three. Thank you. Go ahead.
Yes. Good morning, colleagues. My name is Duba Christopher, Director General of Public Health.
The microphone needs to be sorted out.
Again, good morning. My name is Duba Christopher Nyan, the Director General of the Liberia Public Health Institute. Repeatedly, we want to thank you for all of the presentations. We've heard repeatedly about the One Health platform, which the World Bank speaker said was going on, recognizing Liberia and the other countries. We see the emphasis on animal health, human health, environmental health. And in the recent times, Liberia has begun to bring to the fore the question of plant health. We seem not to be emphasizing plant health when plant health is part and parcel of the human environmental survival chain. And so will this conference of ECOWAS as a body begin to look at that and emphasize that? We raised this at the RETAC meeting recently, and we thought it will come to the fore here. So thank you very much, and we look forward to delivering a concept paper on that is in preparation. Thank you.
Okay, thank you. That question will be for Frank, but let the next person take the question. Next person, please. The person is over there in white. Thank you.
Good evening. Good afternoon. My name is Pharmacist Mubarak Zberu. So my questions goes to the ECOWAS chairperson. First question. I just want to get clarity on how or who ensure capacity strengthening and advocacy beyond just the national level, but also at the subnational level, and ensuring the community ownership of the resident program. So my second question is, I think goes to the first presenter for the Ready Safe program. I want you maybe to just itemize to us what are those interventions that works different countries across the West African region, and how can we ensure the scalability of a highly context-specific interventions other countries within the ECOWAS region? Thank you, and over.
The last question. Thank you.
Hello, I'm Dr. Serge Agbo. As we're working towards a new funding mechanism for health security funded by World Bank, the HESP or HEPERD, we're just trying to figure out how can we ensure that HEPS will be a project that may be fully funding or complementing the NAPS implementation. As we know, in most countries, there's no match between the program, the World Bank. Initially, when we started with REDICE, for example, there was a REDICE plan, a global health security plan, and a NAPS. They weren't aligned. But now that we're going to be moving toward a new funding mechanism with World Bank, how would we ensure that these funding will fully complement or be used for NAPS implementation as well? We want to move towards the vision of improving our IHR indicators. The second quick question is about Cote d'Ivoire. I'm trying to see if there is any opportunity for Cote d'Ivoire to also benefit from this funding, as they were not included in neither REDICE 1, 2, 3, or 4, and we're having this new funding stream. Is it any opportunity for Cote d'Ivoire to benefit from HESP or HEPERD funding? Over.
Okay, the first part of your question I will direct to Mr. Grobogri, and the second part I will direct to Frank. So please, the panelists, let's quickly answer these questions. The hall manager has told us that we have to leave. So let's start from Professor Benjamin, answer the question, then Mr. Grobogri. You want microphone? Yes, I do there.
Hello. Okay, so thank you very much. You asking about tangible interventions that will give high impact. Well, in terms of regional disease surveillance, I think that if we're able to scale up REDICE, because there are some countries, just like I think Cote d'Ivoire just mentioned now, there are some countries that have not, gone into this basket of regional surveillance being sponsored by the World Bank or any other funder. So I think if it's possible to, because the Red Sea project, just like we have presented, and all the panelists have also tested these, gave great success to regional governance. So if there is a way to upscale this in some countries, or even begin to help those who have benefited to do what I would call horizontal scaling up, okay? So they get, the subnational levels involved in, disease surveillance, that will create a lot of impact. I don't know if this answers your question. Thank you very much. And sorry, let me just use this opportunity because I know you won't give me that opportunity. I just want to say that Grobi, the coordinator for Red Sea in Guinea, was very wonderful. In fact, most of the thematic areas which we looked at, they scored very, very high. It is only in Guinea that you will see even a tiny part of agric people or environmental people being part of that collaboration. In Sierra Leone.
Sorry, Prof, we don't have enough time. I think
in Sierra Leone, it
we
was not
understand what you are trying to do.
and so on and so forth. So
Thank
I just want to say thank you to him,
Okay.
Yeah, thank you.
Govogui, please go ahead with your response.
Merci beaucoup. Je pense que un des éléments importants pour la durabilité des interventions, c'est d'abord d'inscrire des grands programmes dans nos plans nationaux de développement sanitaire. Je veux particulièrement parler du cas de la Guinée. Nous sommes en train de passer de l'ancien plan décennal 2015-2024 à un nouveau plan de développement sanitaire 2025-2034. Donc, les 10 prochaines années. Et il y a beaucoup d'innovations à l'intérieur. Il y a, par exemple, tout ce qui est la marche vers la couverture santé universelle, mais il faut aussi inclure de façon très sérieuse toutes les questions relatives aux maladies émergentes et réémergentes et leur allouer un budget conséquent. Il y a quelques années, nous étions autour de 4,6% du budget national alloué à la santé. Je pense que ça doit progressivement, pour certains pays de l'Afrique de l'Ouest, y compris la Guinée, aller au-delà de 6-7%. En principe, on doit être autour de 15%, vous le savez très bien. Et ça, c'est un point important. Le deuxième point important, c'est de former les masses critiques en termes de ressources humaines et de travailler, comme le disait le Dr Sani, à la coordination des interventions avec les autres secteurs. Parce que la surveillance des maladies, ce n'est pas que la santé. Donc, vous avez la communauté qui est le premier rempart et ainsi de suite. Donc, si on prend cela en compte, que ce n'est pas seulement des questions de santé, que c'est une question de développement durable, à ce moment-là, on pourra regarder comment est-ce qu'on peut rehausser le budget de la santé pour en faire des interventions plus durables. Merci.
Okay, Frank, quickly. Thank you.
Merci, merci beaucoup, Segun, et merci pour les questions qui ont été soulevées. De la part du Libéria et cette question sur le concept d'une seule santé qui doit être étendu à la santé des plantes, je souscris complètement à cette approche. D'ailleurs, en Guinée, lorsqu'on avait considéré la fièvre afteuse comme cible pour les activités de Rédicé, elle n'était pas sur un risque de contamination des populations humaines, mais bien sur le fait que les œufs de trait qui étaient affectés par la maladie n'auraient pas été capables de travailler dans les champs et qu'on aurait compromis les récoltes, ce qui était une atteinte à la sécurité des populations. Donc, on voit que le concept de One Health nous permet de naviguer cet espace et d'aller toucher les questions là où elles sont. Donc, tout à fait d'accord avec ce commentaire. Sur l'alignement, avec les les plans de sécurité des pays, effectivement, Rédicé et maintenant ESP contribuent au financement de ces plans. Et je crois qu'il faut faire très attention à la façon dont on approche ces questions-là et au fait de ne pas être lié aux donneurs. C'était un peu la question qui a été posée tout à l'heure sur le panel, et donc attacher une grande importance que ces plans soient financés de manière domestique et durable. Quand on a monté le fonds de lutte contre les pandémies, le Pandemic Fund, on a fait vraiment très attention à ces aspects-là. Et dans les demandes de financement, on a attaché de l'importance à la demande qui était faite, à ce qu'on appelait le co-financement et le co-investissement. Le cofinancement étant ce que les institutions de mise en œuvre étaient capables d'amener à côté du grant qui était alloué par le Pandemic Fund, et le co-investissement était la part du pays. Donc il faut continuer à garder un œil là-dessus. Et c'est un point extrêmement important pour la durabilité de tous ces programmes et la souveraineté, j'allais dire, de ces plans dans les pays.
Thank you.
Okay, thank you, Shogun. And there is an issue, a question. I don't know if I get it right, but what I understand from regional to community level. So we have a way of doing business at the regional level. First of all, we develop regional strategies with member states, and those strategies are approved by the decision-making bodies of the region. Then we support countries to develop national strategies, policies, then going down. That's how our framework is. And in addition, of course, we develop regional programs like REDC and others to support the implementation. For example, within the REDC, you see we established those epidemiological surveillance centers that really is very at the district level. So that's how it works. And currently, Wahoo has developed a regional strategy for community health. This was approved by the last Assembly of Health Ministers. So that's how it works at our level. Thank you.
Okay, thank you very much. I think at this point, we have to put this session to a close. Our landlord has refused to take additional rent. He just wants us out of here. Thank you very much. Please, let's put our hands together for everyone. On behalf of the Lassa FIFA conference, I want to thank all the panelists, the presenters, and also everyone for being part of this session. Thank you very much. Have a nice day. Thank you.
Dear colleagues, please, just wanted to inform you that we'll be having a session just after this one, organized by WHO. So we really kindly request your stay. I mean, for really interacting and exchanging together around different modalities for preparing, responding, and controlling Lassa fever outbreaks in West Africa. So your patience will be very much appreciated. Thank you. It will just take us maybe 5 more minutes before we start. Thank you very much. Thank you so much. Thank you. Thank you. Merci beaucoup. Oui, très bien. Docteur Globogui Moustapha, le coordonnateur de la Guinée. Ah, tiens, ma balle. Oui, oui, très bien. Restez avec. On aura le temps. Oui, je suis là. Oh, excellent, s'il vous plaît. Je suis là. Venez pour une photo. Pendant qu'on se met en place, I would like to invite my colleagues from WHO to get ready to join us on the stage. I'm referring to Dr. Pierre Formanti, Dr. Etienne Koua, Dr. Cheble Traore, Dr. Rina Doshi, and Dr. Aminata Kobi. Thank you very much. Thanks. Ah, directeur, j'espère que vous n'allez pas très loin. Voilà, merci beaucoup. Merci, merci. Merci beaucoup. Merci, merci. Très bonne session à vous. Merci. It's fine. Cheble, can you call the colleagues? Yeah, call them. Yeah, you can ask Senabu to do that while we are just call people to come and then we can start. Just 5 more minutes and thanks for your patience. I know this won't be easy. It's just before the lunch, but I think it can be interesting to have this conversation. Rina, please join the stage. Thank you, Dr. Amadouba. Thanks for coming. Welcome. Dr. Etienne Kwa, please join the stage. Thank you, Dr. Danet Jazz. Please join us. Pierre, where is Pierre? Merci, Dr. Serge. Tu peux appeler Pierre? Ah, OK. Dr. Pierre Formanti, merci beaucoup. Tu peux t'installer juste à côté, comme ça, je commence avec toi. Just have a seat here. Dr. Kwa, may I ask you just to come close here? Okay. So, colleagues, without further ado, I will kindly suggest that we start. We have almost 1 hour and 15 minutes for discussing around the capacities for managing Lassa fever outbreak in West Africa. My name is Cherno Balde, and I'm working as the hub coordinator for WHO in Senegal. I'm based in Senegal, and it's really a great honor and opportunity to be here with you today to discuss about those capacities in managing public health emergency, mostly Lassa fever outbreaks in West Africa. I would like to start by thanking WAHO, the West African Health Organization, for giving us this opportunity. It's one of our main partners in WHO, for working around these different issues. And I would like also to commend here all of the different guests which have really given, daytime to come and to listen to us. I will not mention names, but I'm seeing you. Thank you so much for being around. So this session will be somehow, the title, I will not say will be, is a bit maybe misleading, but we wanted to have this point of presenting the WHO Dakar Emergency Hub as just an entry point for this discussion. the overall objective of this session is to share and discuss with you about the different ways that WHO has been working over all of these decades for preparing, responding, and controlling to Lassa fever. I have some really great colleagues which are with me here, and I'm really quite very pleased to see them. A lot of senior colleagues coming from different level of our organizations. And if I can start, I would like to start with Dr. Pierre Formantier. Dr. Pierre Formantier is a veteran. I don't know if that's the right word in English, mais c'est un vétéran in terms of public health. He's been working for WHO for years and years now, and now he's resting, but as you can see, he's not really resting because we need him, we need all of his expertise. So then secondly, we have Dr. Etienne Kwa. He is the head of our health information program within the regional office in Afro, looking at all of the data, information related to public health emergencies in Africa. Welcome. Dr. Janet Jazz, on the third place here, she's our lead and our guru in terms of medical countermeasures, for supporting the response to different infectious outbreaks, but mostly also on Lassa fever. She has gone in all of our countries where we've been having these outbreaks over the past few years. Thank you, Janet, for being here. And then we have Dr. Aminata Kobi. She's our expert in terms of health promotion, communication, and community engagement. As we all know, outbreaks start at the community and they have to end at the community. So having her with her perspective will be something very useful. And then Dr. Rina Doshi, she's our expert in terms of vaccine. Vaccine, not only vaccine for Lassa fever, but vaccine for Ebola, vaccine for many other outbreak-related diseases. Thank you for being here. And last, not the least, Dr. Cheble Traore, our guy from the One Health perspective. He was giving a kind of very interesting presentation this morning. I was listening to that. So having that perspective of the human health, animal health, environmental health. So it's really something which is important. So colleagues, this is the panel that we are having. And so we're going to start. If I ask you to move to the next slide, please. Thank you. So this is the plan that we are having, that we are proposing to you. Obviously, I have already started with the introduction of the panelists. So for the next 15 minutes, I'm going to talk about the Dakar Regional WHO Emergency Hub, which has been open just about 2 years now, but which is the operational arm of WHO for really supporting our member state countries, working with partners for, again, preparing, responding, to public health emergencies. And we're going to stop there once we finish that one with some question and answers. I hope that you will be having some interest and, questions for us, first to understand better, but at the same time also enriching us, giving us your feedback, your perspective on how you are seeing our work. And after that, I'm going to share now, from the different colleagues here, their perspective on their respective expertise, on how we are handling these different issues. And at the end, as I was saying, I really want this session to be as dynamic as possible. We are not here for giving lessons. At the contrary, we would like to hear from you and to see how we can continue doing this work. Given the complexity of these outbreaks, not only one organization, one person can do all of this work. So we really need to come together to discuss and agree in this type of instances. Next slide, please. So starting with this point, as I was saying, this is, I don't know if there are some people here who have been in Dakar, Senegal recently. This is our hub, which is located in Diamniadio, in the new kind of city of Dakar, going to the airport, and which has been somehow opened about 2 years ago. Next slide, please. And the opening of this hub really try to answer to different issues, given, first of all, this number of outbreaks that we are seeing here, starting with this one. This is the monitoring of all of the different public health emergencies that we are doing in the 47 countries that we are really, supporting by Afro. And what you can see here, which is quite very important, usually I used to hear now everywhere in Africa, we have more than 100 public health maybe signals or emergencies per year. And as of now, this slide dates of maybe 1 week or 2 weeks, we are already at 111 signals. So definitely more emergencies, and most of them somehow coming from West and Central Africa, as you can see. And also a variety of them being either outbreaks or maybe outbreaks occurring in normal situations or maybe in humanitarian situation. And you can see the causes of those outbreaks. So it's really major, again, to have this opportunity to discuss here about these major burdens which are affecting our population. Next slide, please. The logic of the opening of the hub in Dakar. You remember all of us about the Ebola outbreak in 2014, 2016 in West Africa. And one of the recommendations of our member state and of our partners was to decentralize the regional office of WHO Africa, which is based in Brazzaville, in different locations where we can be closer to countries, closer to our partners. And so Senegal and Nairobi was selected for hosting our hubs. So this process started in 2017, and we've been moving quite very well, in trying of scaling up the capacities of those hubs, starting with the movement of few search people, expert people to be based there, to now to these major infrastructure that you have seen now in Senegal. The main objective, as I was saying, is to constitute the operational arm of WHO closer to countries and facilitating the coordination, the engagement, and the work, the mutual work with our different partners. We have a plan to open a third one in Nairobi, in South Africa, but this will probably come later on. Next slide, please. This is just to show you the hub was opened in end of December 2023. By the highest authorities of Senegal, and this was our previous regional emergency director. And it's really a kind of big office where we have almost 100 of offices, but also a kind of major storage capacities. I will come back to that later on. But what we have learned, since 2014 to now, one of the major elements for addressing public health emergencies is about the operational support and the logistic capacities. How far you can be strong, how far you can be smart if you go in the field for responding to public health emergencies. If you don't have those logistic capacities, it won't work. How smart you can be, how good you are if you don't have those elements. So one of our strategic thinking is really to reinforce those supplies capacities, health logistic capacities, but at the same time, all of the health logistic component for reinforcing the strengths that we had already, around the epidemiological surveillance, but obviously all of the different case management. And as you can see, we have a major auditorium there. So I'm inviting all of the different partners, if ever you have an event to organize in Senegal, you are very much welcome, especially from countries. We are a member state organization. We are there for you. We are the secretariat of you. So you are very much welcome. Next slide, please. Obviously, there is the infrastructure, but inside of that infrastructure, you have people. You have people, you have technical people, variety of technical people, and multidisciplinary people, really quite, I will say, strong people, working every day, 24/7, for really trying to detect, prevent, respond, to different public health emergencies. I'll not go too much into details, but we are organized into 4 teams. One team working on preparedness, one team working on response, one team working on health information, and the other team working with the operational support and logistic capacities. It's really that joint work and avoiding all of these silos, which can really bring us all of the richness, all of the capacities, all of the impact that we are looking for, for handling properly and effectively public health emergencies. Next one, please. This is few elements, because we are here for talking about Lassa. I can tell you our team working on preparedness have been using for years now this tool that we used to call strategic toolkit for assessing Lassa fever. Not only Lassa fever, but all other outbreaks at risk. So this is a work, as you can see, covering the 47 countries, where you can see also really the different countries where an expression of maybe danger or risk or threat has been really, highlighted by our member state countries saying, oh, Lassa fever is really a major issue. And as you can see, we are not going too much into details, but Nigeria is there, Guinea is there, Sierra Leone is there, and this is what the epidemiological information are giving us. And one point which is important, I will not go too much into details from these countries. I'm from the regional office, so we wanted to have a regional perspective in our analysis, in our understanding, to allow us, to mutualize all of the different effort connections that we can get from the different countries. So this tool is really important. It's something which is updated very regularly, working with the different countries, but also with the different partners. And you can see the degree of maybe the threat between the different countries, with the very high, the threat, and to the very low one. Next slide, please. This is the seasonality. We'll be coming back to that also later on. But, into this tool, we can even assess somehow the level of seasonality. We'll be sharing this presentation to know exactly, where are we really expecting these different, Lassa fever. Because once we have that component of predictability, I think it's really much easier to plan all of our response intervention, all of our response action. It's a quite very powerful tool, which is available in different countries, for helping us in guiding our actions. Next one, please. This is the component around the health information, and the Dakar Hub is really hosting a major data, a major center of excellence, which is led by Dr. Etienne Koua here, for really working around the data, the artificial intelligence, all of the different dimension and component. And I'm pretty sure he will be able to come back to this one later on. But the disease modeling, the genomic surveillance, all of the different coordination with partners, a lot of work is ongoing there. I'm pretty sure he will tell us later on how far, this is used for not only for Lassa fever, but also for all other, public health emergencies. The public health intelligence is a major one. I met someone today in the corridor here. He was indicating to me he's been attending to all of these workshops and trainings that we are organizing in Dakar around the EIOS, the epidemic intelligence from open sources, which is a major tool, a very powerful tool for detecting and timely, different signals of public health emergencies and to trigger quick and rapid and effective actions. Next one, please. Coming back to the component around the operational support and logistics, we will not hear that much, but from what we have seen today, as I was saying, you have all of the soft or capacities that you have, even if you are deployed, for getting to that place, for being able to be functional in those places, to be able, in remote cases, we are all following what is currently happening in DRC. With the 16, Ebola outbreak, which has been declared very recently by DRC. Today, all of the colleagues are trying, to get in, but it's a really major challenge. So whatever knowledge capacities that you have, if you don't have that component, my colleague here, Janet, she's waiting for going to DRC. And reaching, from Kinshasa to Kasai, it's something. So how can we really integrate that component? And this is one of the major work and function for the Dakar Hub in terms of operational support and logistics. Next one, please. And one of the implications of that capacity is about 2 years ago, 1 or 2 years ago, we wanted here to thank Nigeria. Nigeria, given the challenges that we are having for getting ribavirin for the different countries which are facing, these different outbreaks of Lassa fever, but also others, Nigeria CDC gave to the Dakar Hub, I don't remember how many millions of doses of ribavirin, which were stocked in Dakar, because we have those capacities of stocking, these different medicines at a very low temperature, at the adequate temperature, is not something which is easy. We can see it like this, but getting that and to have this kind of warehouse, which is, which is not on the custom. I don't know how to say that from our OSL colleagues, but we are not, we don't have to make any declaration at the custom. We can take things from Dakar and to move them all over the world, for really helping the people. So that closeness, that connection, those facilities and capacities is really a major trigger for helping, responding timely and effectively to these emergencies. Next one, please. Yes, so I have already spoken about this one, maybe all of the dispatching that we have done on the OSL side, but it's really one of the CNR is really something which is very sensible. And if I have something here to share, I mean from different organizations, from the ministries of health, and we know this is really a kind of major weakness within our member state countries, we have to invest on this component if you wanted to get very far in responding, I mean, to these different emergencies. Next one, please. Those are just some pictures and that we wanted to share. On the first one, as you can see, the Dakar Hub is also becoming a kind of center for training. And this was the first training that we organized this year with you, Janet. We are not only talking about, I mean, the infectious diseases, but working with people for reinforcing the ICU capacities, the intensive care support, I mean, that we are providing to the people based on our experiences on COVID. So we organized with Janet, it was a kind of regional training, you know, for really capacitating our people working in emergency rooms. That was something which was very important, very excellent. The other pictures are the ones that we are handling in DRC. I will have the chance to come back to that now, because from Dakar, we've been supporting very, very closely all of these different emergencies. Next one, please. Next slide, please. Yes, so just coming back to DRC. I mean, this is just to give you a snapshot again on the different, the work that is done. In DRC, we were following this situation before, I mean, in Eastern DRC, as you have all been following. For the past 1 year, I mean, monitoring the situation and really triggering critical actions. That was the situation in before the falling, I have to say, of Goma, I mean, with all of these different camps. But that situation was monitored from us and helping, I mean, for that response. Next one. Few pictures just to show you, because I mean the component, I think the visual is really important. If you go to the next one, we have some pictures explaining, I mean, the work which is done, I mean, by our teams. As you can see here in the middle of Eastern DRC, you know, helping all of these people. That was a very kind of complex situation, because in addition to the humanitarian situation, we're having this outbreak of Mpox. And those connection was really there, and having the possibility of handling both of them, and obviously then, which were complicated more again by the security situation, was a major one. It's not the first one. We remember the Ebola outbreak in 2018. How was it? So that support was also provided through our structure. Next one, please. I have just few more to share. Next, please. I wanted to keep this one. It's not necessarily Lassa fever, but from the hub, as I was saying, all of these signals that we are following. It's the second year or the third consecutive year that we've been talking about the ascites syndromes affecting not only, I think it was in Nigeria, Niger, and even Benin, I think, a little bit. So it's really quite a challenge, and that monitoring, and that's how I think we can really gather the real information. We've been seeing that as we are expecting Lassa fever from December to January or February in Nigeria, that it will pop up. So it's really, that's the type of elements that we are learning and also bringing, and also obviously building our knowledges and expertise for supporting our member state countries. This regional, sub-regional component, the connection between the people. Obviously, we all know all the importance of these elements for really getting the things done rightly, because people are moving, people don't know borders, diseases don't know borders. Next one, please. Yeah, maybe we can move to the next one, because this one, it's about all of the component around the coordination of the partners, and that's why I wanted to comment here the work of WAHO. We've been working with WAHO for all of these different, months, for trying as much as possible. The landscape of the different partners is quite very huge today, very complex. How can we all work together in this context of obviously scarcity of resources without making any duplication? And if I wanted to finish, I think, this presentation, I wanted to share this experience also of the development of the emergency medical team in Senegal that you have heard about last year. With the opening of the Dakar hub, it facilitated, it triggered, the finalization of the certification process of the first African emergency medical team with the Army of Senegal. So bringing together the Ministry of Health, the Ministry of Defense, WHO come in for having the first emergency medical team capable of being deployed worldwide, in 72 hours, providing care to thousands of people, for almost with a kind of major autonomy that was really major. And with that, just 1 week after the certification, the team was already on the ground in Senegal, helping, addressing, caring, for the population. That was really important. Next one. And with that success also, we were capable of engaging, other donors for getting this thing done in other countries. And the success of that intervention give us, few, in French we say petit frère ou petite sœur. We are working on that one for really getting order, not international emergency medical team, but national emergency medical team in different countries in Mali, CAR, Chad, and also Cameroon, for being able, to get to that level. Next one, please. And I think I'm almost at the conclusion of my presentation. Yeah, these are just a few elements I wanted to share. As I was saying, you have all of these different components, and all of these different components is pieces, to help us again to understand, respond, and control these different emergencies, including, the Lassa fever component. And the center, the hub, is becoming more and more also a kind of training, capacitation center. If I count it well, we have been able, to engage, I will not say train, but engage and support and interact with more than 1,000 people for almost the past, 2 years. Capacitating them, discussing with them, getting them, knowing, listening to people, coming from the countries, learning from them, I think, and then after that, obviously, transforming that knowledge for the other people. So this is what we have done. I think that will be my last slide, if I'm not mistaken, and I thank you for your attention. Thank you. I'm presenting, I'm the same time also the moderator. So as I was saying, this was just, I think, the first part of this conversation that we wanted to have. With the objective of, again, showing somehow some of the work, capacitation of, and tools and mechanisms of the WHO in supporting you guys, member states, but also partners for handling these public health emergencies. So let me stop here. I don't know if my colleagues wanted to add something on this one, or maybe if there are some specific questions at this point around what we have presented before also we go more in details now, more in depth around the Lassa fever and to make the linkages. Oui, s'il vous plaît. I don't know how we can move with the mic. Okay. The colleague here can help us. 1, 2.
Thank you so much for the presentation. My name is Emmanuel Dualo from the National Public Health Institute of Liberia. You spoke about the storage of ribavirin at the regional hub. And that information is very useful, and thank you for that. My concern is, I know the country offices are working along with the regional hub, showing that countries that need the ribavirin supply get them as required. It's there for the treatment. So my concern is what is being done to expedite the process of the drug reaching to the countries that need them for ribavirin, for the Lassa fever treatment. Where Lassa fever, the earlier the ribavirin is initiated, the better the outcome of the patient. So that's one concern. The second is I have done all the papers and I have seen that there exists scientific argument when it comes to the efficacy of ribavirin. That the evidence presented in a cohort in a clinical research, that the evidence presented that the recommended ribavirin for usage for treatment of Lassa fever was not sufficient enough. And so there have been different arguments. So I want to know, where are we? I know WHO, I'm not seeing any official position on WHO to say use ribavirin or don't use ribavirin. So I want to know where are we now as far as those arguments are concerned. Thank you.
Thank you so much, sir. Thanks for the question. Let's take a second one. And okay, 1, 2, 3, 4. Okay, maybe by the geographic proximity from my professor. Please go ahead.
Okay. I'm going to talk in French. I could do it in English, but let's do it in French. S'il vous plaît, je constate que vous utilisez votre position de hub à Dakar pour mettre à profit les expériences développées dans différents pays. Alors, quel est le chemin que vous suivez pour mieux institutionnaliser cela afin que les pays apprennent les uns des autres et que les prestations de services soient moins coûteuses et soient moins pérennes et que le continent ne sorte pas de l'Afrique pour aller chercher les choses qui sont possibles d'être faites ici.
Yeah.
Ça, c'est une chose.
Mm.
Et lié en liaison avec ça, comment vous utilisez ou comment comptez-vous utiliser l'intelligence artificielle pour mieux institutionnaliser ça pour une meilleure prestation de services?
Merci, Professor. Merci beaucoup. Let's take the question here, and maybe you can try to answer to these three first questions before I forgot. Okay, you have the mic here. Please.
I am Professor Mariam from Ahmadu Bello University Zaria, Nigeria. I was wondering, the children you showed with ascites, did you find out what was the cause? Could it be viral, non-viral, cardiac, renal, and what have you done about it?
Okay, thank you. Let's start with these ones, and we can. And you know, I'm lucky enough to have all of my very experts and capable colleagues here. I'll just start maybe with just maybe one or two answers, and then I can give the floor to my other colleagues for helping to answer to these different questions. The first question around, I mean, the shipment of the ribavirin, I mean, the speed and the capacities. I agree with you. I mean, it's not an easy process, absolutely. But I can tell you for sure that we have some experiences, maybe not from Liberia, but from Sierra Leone. I've been witnessing that, you know, with this stock that we are capable, I mean, to get from Nigeria CDC, we are capable of shipping that very, very quickly. So it's just probably a matter of connection, I think, with our country offices. But whenever the requests come to us, because, you know, we are a kind of structured organization, the Ministry of Health, they go through, I mean, our country office, and once we have that, they assess the request, and then, but I can tell you these processes can be very fast. And it has happened where we even took one of our colleagues, you know, to go with the different shipment, to take a plane, if there's no other capacities, to move. So it's really important that to know that, you know, and I'm really happy to hear about the interest of that. And these capacities need to be really definitely implemented, also rolled out at the country level. So that that's probably the answer I would like to make. Now, around, I mean, the effectiveness of the ribavirin, I wanted maybe to ask Janet and also maybe Pierre to help us on that one, if you can. Mike, here, please.
Is this one working? This one is working. Okay. On the ribavirin, thank you for your question. There will be a special session on ribavirin on Thursday, the 11th of September, where we will discuss the pro and the cons. But let me take it briefly. At the 80s, there was a major clinical trial in Liberia and Sierra Leone that was published. Recently, finding this result and going back to the hard data, it was evident that Lassa fever patient with transaminase over 150, the case fatality ratio was decreased, but for the patient, the transaminase lower than 150, let's say the mild cases, the CFR in fact was compared to historical data. So basically what I'm trying to say here, and then several meta-analyses have been published showing that we do not have good clinical trial without any bias to say and claim ribavirin is the best today. Still, kinetics studies have been done, notably in Irois 2 years ago, showing that the distribution is not what was expected in terms of I would say antivirology. So the percentage of the antiviral drug ribavirin in blood, that there was difference between men and women. So at the end of a lot of discussion, what is important today with the use of ribavirin is to document the use of ribavirin and to enter in clinical trial so that we can finally find a way to one antiviral drug that would be working well. I'm saying working well because there is side effect also with ribavirin and probably something else is needed. We save more life of severe cases. I don't know if you got something.
Yeah, Janet, maybe you can complement, please.
Sure. Can you hear me? Good afternoon, everyone, and thanks for having us on this session. It's very exciting. Just to add on what Pierre has said, I think in approaching Lassa fever or other emerging diseases, we start to think about the care package. So don't think about one intervention being the silver bullet that's going to save the life. It's actually a package of care. And at WHO, we're using the word to describe that as safe and scalable care, right? So that means from the whole patient pathway, from the early diagnosis, to the early supportive and symptomatic treatments. And I want to emphasize that the importance of supportive care, the importance of fluid resuscitation, the importance of correcting electrolytes, the importance of, monitoring urine output for the development of acute kidney injury. So those are examples of a good package of holistic care that patients with Lassa fever and other emerging diseases or other causes of, perhaps viral sepsis need as part of their care package. And with that as well, when there is an effective treatment, that whole package of care can really save lives. And I agree with Pierre on the interpretation we have at WHO around the questions about the efficacy or effectiveness of ribavirin. So what we strongly encourage, and many of you, not many, some of you in the audience are already working on this, is advancing clinical trials to evaluate both, ribavirin, which is an old drug, but also to evaluate other drugs. I think this is an area for research and development that we need to find efficacious drug and really the pipeline. Where is the pipeline of drugs? And also looking at the antiviral, the anti-specific treatments, but also looking at the host therapies or immunomodulators. And I think we're going to see some important posters. I think it's tomorrow on the use of dexamethasone as well with antivirals. So I think there is much more we can do, but we should do it through clinical trials, through collection of standardized clinical data, looking at patient outcomes, looking at severe adverse events, and really try to find what really can reduce mortality. And with that, as you generate more evidence, the communities, then WHO can update its policies and its recommendations and its guidelines to reflect that. But we need to do this together collectively and in a scientific manner. Thank you.
No, thank you very much, Pierre and Janet, I think, for these clarifications. Clearly, I mean, the issue around the use of the ribavirin, I think it's a kind of, quite dynamic, I think, exercise and dynamic topic, whereas they were saying, I mean, there is a lot of work which is ongoing there, and I think we all need just to participate into this exercise in a very scientific manner, I will say. So maybe let me move to the next one of the next question, which was on the use of the artificial intelligence, I mean, for the work that we're doing in the Dakar Hub. And there's no one who is better placed to answer to that question than here, Dr. Etienne Kwa. So Etienne, can you please share your perspective on that one? Thank you.
Thank you very much.
Je peux y aller en français, je pense que la question était en français, oui.
Merci beaucoup, professeur, pour la question. En fait, la question c'était deux questions en réalité. La première partie faisait référence au fait qu'on pourrait encourager ou développer mieux l'apprentissage entre les pays. Je vais d'abord passer un peu de temps là-dessus. Alors, à l'intérieur du centre du Hub de Dakar, il y a un centre d'excellence et c'est exactement l'objectif. L'objectif de ce centre, c'est de vraiment développer cet apprentissage entre les pays. Donc, c'est une plateforme qui est là et on a commencé à voir déjà des visites de quelques pays, y compris la Côte d'Ivoire qui a déjà visité, pour justement voir comment ils peuvent apprendre avec les autres. Il y a la Namibie, par exemple, qui est aussi passé pour pendant une semaine avec les autres. Et il y a eu pas mal de formations entre pays. Par exemple, on a parlé tout à l'heure de IAOS, où les pays se sont retrouvés pour devenir des champions en réalité, en apprenant entre eux. Donc, c'est vraiment une très, très bonne question. On doit encourager cela. Et c'est vraiment l'objectif du hub et surtout de ce centre qui est à l'intérieur. Maintenant, pour arriver sur l'intelligence artificielle, c'est absolument cela. C'est-à-dire que, d'ailleurs, le mercredi, il y a une session qui sera dédiée à voir qu'est-ce que ça apporte, voir une meilleure utilisation de la chose. C'est vraiment dans ce sens qu'on sent. C'est-à-dire que c'est quelque chose qui existe et qui, évidemment, on voit déjà, contribue tellement qu'on ne peut pas le laisser. Il faut pas profiter. Donc, le centre a commencé pour déjà vous expliquer un peu comment nous avons procédé avec les jeunes. Donc, on a créé un programme des jeunes qui peuvent venir faire des stages, des volontaires aussi, qui viennent et qui apprennent tous ces outils. Par exemple, pour la modélisation, autre chose. Comprendre même déjà les données. Quand on regarde, par exemple, et je le dis toujours, quand on fait les EDS, on a un tas de données. En général, on fait des analyses avec quelques indicateurs multiples. Mais il y a tellement d'informations contenues. Et quand on fait des EDS, il y a forcément beaucoup de choses qu'on peut apprendre. Donc, c'est là où l'IA est assez approprié pour nous aider. Donc, on l'applique dans beaucoup de domaines déjà pour par exemple, tout ce qui est risque. Vous avez vu un peu le calendrier de risque, tout ce qui est saisonnalité. On peut faire la modélisation pour voir un peu où on va dans les hotspots. Quand on parle de la surveillance, dans le cas de Lassa, par exemple, on n'a pas forcément assez de moyens pour faire la surveillance d'une grande zone. Mais si on sait exactement les poches où le problème se trouve, on peut renforcer notre surveillance quotidienne dans ces endroits-là. Donc, pour résumer un peu ma question, et on attendra mercredi pour continuer la discussion sur IA, c'est absolument c'est là où le hub de Dakar continue.
Excellent. Merci bien, Étienne. Je pense que aussi, juste pour ajouter, pour vous rassurer, professeur, je pense que cette composante de formation mutuelle, d'apprentissage mutuel, je pense que vous me l'entendez en parler depuis le début là, c'est quelque chose que nous valorisons extrêmement. C'est quelque chose vraiment, ramener les gens, apprendre d'eux. Vous savez, quand il y a eu l'épidémie de Mpox qui a été déclarée comme urgence de santé publique de portée internationale, une semaine après, on était avec WAHO et l'Institut Pasteur de Dakar pour faire les premières formations pour les gens, pour les techniciens de laboratoire, pour la détection et la confirmation de ces cas. Et des gens de la Guinée sont venus, les gens de la Sierra Leone, tous les 15 pays sont venus. Et vous savez, ils sont venus, non seulement ils ont été formés, mais les gens sont venus d'Allemagne avec les reagents. Donc, on en a donné pratiquement pour les 100 ou 200 premiers cas pour que les gens puissent rentrer avec cela. Donc, cette composante que vous dites là, de plus d'autonomie, je pense que c'est une dynamique qui est là, qui est en train d'être travaillée et le centre définitivement s'engage dans cela. Étienne a parlé de toute la composante de formation sur le data, mais on en fait beaucoup. Tout à l'heure avec Janet, on parlait un peu, on va jusqu'au niveau des soins intensifs d'urgence. Vous savez, avec des mécanismes pratiquement de simulation sur place, de patients à voir vraiment en état critique. Comment est-ce qu'on fait cela? Parce qu'il y a tout ce continuum de soins-là, à commencer par les aspects communautaires jusqu'au niveau de la prise en charge très élevé donc des patients. C'est des éléments importants. Maybe if I wanted to finish maybe with the question around the origin of the ascites, I don't know, Janet, if you want to come in, or maybe I can also, but you start first.
Thank you, Tierno. It's a really important question, and it's unfortunate we still don't have the answer.
No.
But what we have done to support the Ministry of Health of the affected countries was to finally roll out standardized data collection tool, because we really weren't getting the full picture of what the clinical, the symptom onset, the type of ascites, the fluid characteristics, and also the evaluation for the infectious diseases, and then also the evaluation for toxin-induced diseases.
Exactly.
So we helped develop a protocol. We wrote it together with the ministries, with the WHO regional office in Geneva, a research protocol to collect the ascites, and then those samples, I believe, have already made it to a lab to get full
Exactly.
evaluation for a toxin, because we believe it's likely related
Yeah.
to an environmental toxin. So we do hope that that's the work, and that took quite a bit of time to get that rolled out and the samples collected. So Tierno, maybe.
No, exactly. That's the point. And you know, this is again not really inventions. This is what we've been seeing almost 2 years with the same pattern. It's questioned us. It really questioned us. And I mean, as we are somehow maybe years back ago, medical doctors, we really tried to explain the diagnostic of that one. Myself, I was thinking really, the hypertension, portal hypertension, I don't know, bilharziosis, all of those type of things. But at the end of the day, we didn't find anything. You know, we really send that, I mean, to different labs, but probably the environmental component is probably exactly mining activities or other issues. So that might be probably the cause. But as she was saying, I mean, we are working on that end to find out. So let me stop here at the moment and to see if there are some other questions. We have also some panelists here who would like to intervene. Yes, sir, behind there, close to the cameras. A mic, can we give a mic to the colleague? And the second one here. Micro, s'il vous plaît. Si on peut avoir, or if your voice is good enough, maybe loud enough. Not me, but you maybe. Ah, okay. Mine is very weak.
All right, thank you. Lobga from MRC Gambia. And just 2 questions. Thank you for your presentation. One of them is just about who feeds the hub the information. The hub, yes, we do have the hub, but how does the hub get information? And do they have to go through like the country offices, or if say there's an organization that finds out something of interest and they want to access the hub? Then secondly, I didn't really see something regarding, maybe I missed it, about the financing of the hub. Is, let's say, 2 things. With the current landscape that we're experiencing, is it still on WHO's priority, especially when it has to come to Africa? And also keeping the financing, do you think it's better the hub is financing this activity, or the country offices handle their own financing? So just to hear more about that. Thank you.
Thank you very much. Let's take the second question there. Sir, please.
Thank you. My name is Albertus Nyamiana. I'm the National Coordinator for One Health in Liberia. Thanks for the presentation. It has now become glaring, considering the complexities for one sector to address some of these sustained outbreaks in the WAU member states, including this Lassa fever. We know that the One Health approach is very important, such that it brings together multi-sectorial collaboration and coordination in approaching some of these outbreaks. And it has now become imperative that we use the One Health approach so that we can succeed in mitigating some of these outbreaks. Now, in order to enhance the capacity of the One Health Platform Secretariat to perform the collaboration across sectors, nothing has been spelled out to provide a dedicated, sustainable budget line for the operation of the One Health Secretariat. So I don't know whether the WHO regional office also thinks about that. WAU, Africa CDC. If we consider the platform to play the role of bringing other sectors together, we should be thinking about providing a dedicated and sustainable budget line for that. Thank you.
Thank you very much. This is very interesting questions. Okay, let's take the third one and then I think we can complete. Oh, okay. I'm also seeing, my colleague from Liberia. So let's take maybe those two other questions quickly, please.
Thank you very much. Dr. Joseph Okwegwale. I'm the director at the Institute of Lassa Fever Research and Control of Ira Specialist Teaching Hospital. Thank you very much. I'm a bit worried about the current support to mitigate supplies, consumables, and diagnostics, as well as therapeutic or case management for Lassa virus disease. I'll give an example. When you talked about seasonality, I noticed a trend in several countries. Now, what happened, for example, in Nigeria, there's a period of seasonal surge. There are periods where you're going to have very high number of cases, which we call the surge period. And this happens usually between the months of November and March in every year. But in other parts of the year, like other months, you can have like 3 to 4 cases per week, sometimes 1 case in a week, and sometimes up to about 5 cases in a month. But when you get to this short period, it's possible that you could have like 20 cases in a week. And for some cases in our ward, we admit up to 80 patients in the ward at the same time. And then you now have an overflow. Over this period, you have challenges with getting stocks of diagnostics. The current diagnostic we use for the real-time polymerase chain reaction still remains the Altona test kit. Quite expensive. And many facilities will not have these kits to perform these diagnostics. And if you go into the community where there are indigent patients, where we see these patients, you can't find these diagnostics there. They are not there. And there are designated centers where these diagnostics are done. First, sometimes the Nigeria Center for Disease Control that supplies major diagnostic labs may not have some of these kits at some time. And even the therapeutics too, I visited a few centers the last time, and I noticed that some of the ribavirin which they claim to use, which they use for managing some of these patients, I looked at the expiring dates and noticed that some of them have been expired. Then I asked, how long have you used this medication? Some are saying for the past 2 weeks and all that. This is something that we have we still have to discuss. So I really want us to discuss what is the level of support WAHO is bringing in, WHO is bringing in, because we are having lack of these talks for the care of some of these patients and also area of rapid diagnostic testing. These are things we have to look at in our facilities. These are things that we can deploy into our community where these cases are. Rapid diagnostic test kits, not necessarily having to wait for the major test kit, which we may not get to perform the real polymerase chain reaction. Thank you very much.
Thank you very much. Let's take the last question, please. Yes, please, sir.
Juba Chris again from the National Public Health Institute of Nigeria. Is WHO in a position to support countries or regions that would like to carry out certain clinical studies on their own with regard to comparing ribavirin with other drugs? Take taribavirin, which is a pro-drug of ribavirin, causes less anemia, whereby ribavirin itself is highly toxic given the dose that is given. So if you want to compare probably like a double dose and do a relation, is the WHO willing to support such studies? Because we can't continue to rely on a suggested treatment regimen whereby those on the practical field, the clinics, know that there could be alternatives and there could be comparisons. Secondly, following up on the comment of my colleague here from Nigeria, with respect to how diagnostics is a major problem, is WAHO or WHO willing to support countries also that are in a position to develop their home-based or diagnostic testing and regimens, because you can't keep waiting on the Atona kit, and by the time these kits come, sometimes their expiration date is almost at the end. So it presents a very difficult problem in terms of diagnosis and then going to treatment. Thank you.
Thank you very much. Really very good and interesting questions. And I will try to answer some of them. And then obviously my colleagues here also can jump in, absolutely. And for the source of information, maybe Etienne, you can elaborate a little bit more on that. But clearly we have the traditional, channel of information sharing from member states. We are a secretariat of member states of the country, sharing those information, and there is a whole process for really gathering those information, collecting them and analyzing them. But Etienne maybe can elaborate a little bit more on that. And obviously you have also the component around all of these data gathering, from the open sources. Those are the main sources of information. Around the funding of the hub, given the current situation, I think, and it's quite good to mention it, we have demonstrated the added value and the relevance of this hub. So, and I can tell you, in our restructuration, the hub will be there, the hub will continue to be there. And this is something which is very positive. In 2 years, 5 years, we have seen the importance of these structures being closer to countries, being closer to organizations like WAHO, to come and to raise questions. I will not pretend to have answers to all of these questions, but this is the gathering. This is not only an issue of WHO, it's an issue, it's a collective issue, both of member states, but also all of the other partners. And I think this conference is really the right place for highlighting those questions, and then to go back and then to work on them with you, with other institutions and other partners. Maybe let me therefore move to the point around the One Health, just by kind of order of questions, and asking my colleague here, Cheble, to help responding to the question. I think this conversation was happening this morning also around, the valuing or the relevance of the One Health approach. And just mention that you've been, working on this thing to 5 to 7 years or maybe 10 years within WHO. So it's really a critical and important area of work for us. And if you can be brief, I'm conscious of the time, and people might be a bit hungry soon. So go ahead, Cheble, please.
Thank you very much, Dr. Bad. Okay. Well, brief. I know you are hungry and you need to stay, because this is a very important issue. We've been talking about One Health approach. You are here because of One Health approach. That's a favor. It's a complex deal, so nothing. So it requires interaction to take place. That interaction with the rodent, human, and the environment in general. How can you control it? You cannot, one sector cannot. Okay, we have an opportunity. We had a great question from my colleague from Liberia in One Health, working in One Health, talked this morning. Financing One Health, it is one of our priorities, even at the quadripartite level, which means FAO, WHO, WHA, and UNED, and other parties as well. So this, if you're the acronym, you got a problem in that, I can spell each of them out. Now, financing is one of our pillar pathway we look for to support countries to be able to do, so they can generate themselves that resources, because that's where sustainability is. How do you do that? You engage parties, that's fine, but you all the stakeholders. Now the complexity will be the stakeholder. Who do you define stakeholder? As a stakeholder, I'm a stakeholder. Beneficiary as stakeholder. Victim as stakeholder. People with knowledge as stakeholder. You see now, and policy, decision maker. Are they stakeholder? Yes. So these are, that's within a country. Okay, now, one example we gave to push countries to go for sustainability, sustainable financing, is through pandemic fund application. That's where you get the Ministry of Finance we get it on board, and slowly that can be pushed out. The external help can be, country can generate also. My brother, you will agree with that as well. That's the way. But if you can't do it straight, I don't think country will be able to. Slowly, the country can take off and to make it at the decision-making level in budget line. I think that will be the best way.
Okay.
And three things you can take away with. Policy, it is very important for intersectoral collaboration. Without it, it won't be possible. I give you an example for Nigeria. We have done policy briefing, development, and when we came to policy, there was no policy for the One Health, but there were memorandum. There was strategic plan for One Health, which expired in 2020. And with colleague, we will revise it. So now, honestly, yes, even though there is a little bit, but it needs to be sustainable. How can it be sustainable?
Maybe
That now, I will tell you one example. So you will see.
Cheble, I think you were saying three things. So let's take the takeaway of the two other things, please, because we need the, please. Yeah.
Station financing, really, these are very important. But if you don't have it, it will be very hard. But to make it country level, policymakers need to be involved in One Health operationalization. Any policy you have, if come with good policy briefing document, they will support it, and they need to be follow up and accountability. It will be done, definitely. I will give you just few examples.
One. And very quickly.
Yes, sometimes, not for the pandemic fund. When you ask the Minister of Finance of any of your country, they will say, I never heard about this. And so, where is the problem? The problem is the way we do take all the analysis and engage. And that's where the problem is. Believe me or not, it starts from there. If you exclude really the key player, your problem will not be solved. Definitely.
Thank you.
Yeah, okay.
Thank you so much. Okay. Maybe during the lunch. Thank you, Cheble. I think. Okay, 1 second.
I need to stand. You know, in Nigeria.
Okay.
In Nigeria, disease from Togiasi. Who heard it? Who ever heard it? Here in the room. Ecowas did a project on that parasitic disease, very complex. He reduced it in a sustainable manner. So that approach can be applied to Lassa. Why not? Because community empowerment, even environmental engineer, they all contributed to it.
Absolutely.
Google it and take it from me.
Okay. Thank you very much, Cheble. Thanks for the question. You can see the question of One Health. So One Health is really having a great, advocate within WHO. Maybe while moving, and I'm looking at the time, I wanted maybe to give the opportunity also to Rina. Maybe there have been some questions around those clinical trial, vaccines, and all of those type of things. Do you have any perspective to share on this one also from your end? With the patient of Cheble.
Hopefully you can hear me. Yeah, so I think some of the countries here have been working closely on a phase 2 clinical trial for Lassa fever vaccine, which is great. And there are other candidate vaccines that are in development. There's a rabies vaccine that has been attenuated, is in development, also an mRNA vaccine. And there may be more as well. So some of the things that we can think about, and we're going to talk about this in another panel tomorrow, but for those of you who may not be able to attend that panel, just some of the things that we can think about are some of the preparedness activities when these vaccines do become available on the market. So there's two aspects, right? There's that research side, but then there's also preparing for that vaccine. Like I said, we'll talk about that tomorrow, but some of the things that we can do is think about risk profiling for who would get vaccinated, should the vaccine be available. And then also thinking through how you might introduce that. And that kind of ties into my colleague next to me to talk about some of the communications around that and how do you get population to accept a new vaccine. I think one of the lessons that we learned from some of our other new vaccine introductions during emergencies, such as COVID, is that we really need to prepare early on before the vaccine is ready and make sure that populations are ready so that we can make sure that we have a high acceptance among those at-risk populations. I think not a lot of attention say, has been given to this thing, but we haven't figured out how best to develop intervention, to develop that acceptance. I know we touched on that this morning too, in the vaccine hesitancy section.
Excellent. Thank you, Rina. Maybe I can just directly give the floor to Aminata to tell us, because that component around, the vaccine acceptability is really something which is really, really major. And sometimes I used to ask my question, why do I have to get vaccinated? So you ask yourself before encouraging someone else to do it. So just put it on your end. But Aminata, please highlight us a bit more.
Very much. I want to highlight not only
Come closer, talk closer.
I just wanted to highlight the importance of engagement of communities in every aspect of the response, whether it be for trials of vaccination, prevention. It's important for us to engage communities. And sometimes we think that just giving information to communities is part of engagement. Yes, it is, but it means more than that. We need to treat communities as partners. We need to empower communities to take action, from identifying of suspected cases, even to reporting suspected cases as early as possible. And communities should be critically and empowered and mobilized. Not only community health workers, we also need to look at community leadership, traditional leaders, partners. They need to be empowered to be able to engage communities, empower them for them to take action, and for them to know what is going on and be partners in the response system. Planning with the communities is critical, and it's some aspect that is usually left out as we work out with communities.
Thank you very much, Aminata. We are really trying to conclude, colleagues, so just bear with us a little bit. This will be probably the last intervention. So maybe, Janet, I give you the floor to respond to some of the questions around the clinical trials, and maybe any other maybe message you wanted to make, as a concluding remark from your end, please.
Thank you, Tierno. I'll respond to the clinical trials question and then a little bit more around surge and readiness, the other topic that was raised. So in agreement, the WHO is very supportive of collaborative research, multi-country studies that can, quality studies that can answer these remaining questions, and finding effective treatments for Lassa is a priority. So I think that's clear, and WHO is very supportive of that. We are aware, and maybe Pierre may want to talk more about this, about the Integrate Research Trial Consortium that exists. And we know that is testing and evaluating treatments. So that's a great opportunity for that consortium to grow, to get more partners, different countries, different sites, enroll. And I know they've already started, I think, to enroll in a second site in Nigeria, but now let's see how can we expand that outside and have a multi-country clinical trial, perhaps, in the platform type of design where you can test different interventions over time. And that's really an efficient way to proceed. And I think from my colleagues in the R&D blueprint that aren't here would be something we are supportive of. So I also wanted to acknowledge there's also operational research questions as well. So we think about the trials testing for drugs, but there's also a range of operational research questions around early diagnostics, what's the best for initiating the care pathway earlier. So that would be like an operational research question. And also around the surge. You were discussing around, the increase or influx of 80 patients into a facility, and that's very complex to manage. And so looking at that and how can we better prepare for surging can be an operational research question, but also is part of your readiness. So that's going to lead me into the safe and scalable care kind of area of work that I lead at WHO, is really getting countries to start to look at that readiness, because it's going to happen, right? You're in this risk, the time. So what do I need to be ready? What are the supplies? What are the lists of drugs, of biomedical equipment that need to be stockpiled or ready to surge in when the time is right? What are your staffing requirements? How many clinicians or doctors or hygienists or IPC professionals or engineers, clinical engineers that you need to staff, the surge of patients that you may have. So what are those numbers, and are those staff, is that workforce ready to surge when the time is needed, so there's not a delay in bringing in that surge work? The other one I wanted to comment is on structure. And there is a group at WHO that really focuses on looking at the design and infrastructure. So you have a fixed hospital, and maybe that's where you care for your patients with Lassa. But if you need to surge and that's not sufficient, do you use temporary facilities? What kind of facilities are those? And do we use innovative types of facilities where you can still provide high-level care, critical care, perhaps, right? Hemodialysis, if that's ready and available. So how can we make the structures within which we work in also safer and enable delivery of optimal care? And then standards, right? Do you have all your guidelines in place, your SOPs, your checklists, so that when the surge happens, you're ready? So I think trying to look at it from that 5S approach is really, really important around preparing for safe and scalable care. Thank you.
No, thank you, Janet. And when Janet is talking, I'm just thinking about this is what we're doing. I mean, somehow during the COVID. But how have we really learned and built and more on this one? I think those are the key questions that we all need to work on collectively, for addressing these right problems, because clearly outbreaks, emergency management, it's something which is quite very particular, very special, and we really need to build on that. Maybe our last two interventions, let me ask Etienne, if you wanted to answer to some of the question, or maybe also making your concluding remarks. Over.
Thank you very much. I will actually go back very quickly and briefly on the One Health question to recognize that is really a focus and it's important. So as you know, the global architecture for global health, the WHO concept, we have one of the components which is collaborative surveillance. So basically, to Chivle's point, we're not only trying to strengthen One Health, but we're going beyond to really get all the sectors involved. This morning, you could also see the person talking about how it's important to get every sector involved in what we are doing in responding. So that's really to say that we mobilizing, talking to partners, and many partners actually recognize the importance of collaborative surveillance. And we hope that we're going to get some more funding to actually reinforce the One Health approach, plus other sectors that will be involved. The other question that I wanted to quickly answer to is about how the hub gets the information. So basically, the hub is not new in the structure of the information flow. So the hub is playing a sub-regional role, but there's already an existing structure for collecting data. For example, if you take the IDSR, there is already a clear way of getting IDSR data to WHO every week. You also have the IHR for conference that also getting information. So basically, we rely on that. And the hub's role is really to play that sub-regional entity that really helps for the entity in West and Central Africa. I'll stop here. Thank you.
Yeah, and using also obviously the artificial intelligence and all of these other sorts of information. Maybe just to try to conclude here, maybe giving the floor to Pierre. And Pierre, maybe you might not have some questions, but you have been seeing all of these outbreaks for all of these years. He shared a slide with me. I wanted to have kind of the dynamic of outbreaks. And for me, I was looking at from 2018, 2018 to 2025. And then he came with a slide from 1969, I think. So I think Pierre has been following all of these things. So Pierre, please tell us, maybe I can give you, I won't be fair with Cheble, but I can give you a little bit more time, maybe a kind of good 5 minutes if you wanted to share your perspective, maybe your advices, I mean, to countries, you know, how can we work better on these elements, what you have learned. So Pierre, please.
Thank you very much. Yeah, well, let's not go back to the 90s, but after the millennium, let's start when I joined WHO. And we start, in fact, with a big outbreak in Sierra Leone in 2004. And just after this one, our attention go to a seasonal viral hemorrhagic fever, Lassa fever, and we invest notably on the diagnostic at this time, but also on the clinical care, because we are thinking, like Ed was saying, that we need not just to think about one drug, but to think about the clinical care as a whole, including from time to time, by the way, when there is a renal failure, access to dialysis, etc. So, and at this time, it's about it. At this time, Nigeria was quite silent about Lassa fever. The year 2004, 2006, 7. Then we work a lot with the Sierra Leone. 2014, all the people who have forgotten the major outbreak in West Africa of Ebola. And one of the collateral positive effect of this Ebola crisis 2014-2016 was the opportunity to have clinical trials, to also validate diagnostic PCR diagnostic tools and serology, and then have access to this commercial kit for Ebola, and also a clinical trial for vaccine. It was for us when we were able to control the outbreak, a way to think about what to do for other hemorrhagic fever. And just after the 2014-2016, we start to work in 2017 with Nigeria, where they have already started before that, notably with the support of partners like the Bernard Nord Institute, and notably at the Irwa Hospital, and validating the first PCR test together with Altona. And this was really a turning time, a game changer, when notably at Irwa, they have access to more diagnostic, implement better clinical care, put in place a lot of, I would say, research project. I remember, but there was a but, because I remember discussing with the director of Nigeria in 2017, when we were talking about increasing the number of labs in notably in Nigeria, but also in all of West Africa. He was saying to me, what will be the use of reporting more cases and more deaths confirmed with Lassa fever? My prime minister will not be happy with this kind of stuff, you know? And so I was saying to him, really what we are doing every day, what the doctors are doing every day, from Guinea to Nigeria by combating Lassa fever, is not to fill an Excel file somewhere in Dakar or in Geneva or in Brazzaville. It's really to save more life, to develop better diagnostic, but also to put in place clinical trial to better care our patient, probably with better medical countermeasure tomorrow, probably with better vaccine tomorrow, but also with stockpile of these new drugs, of these new vaccine, of this new diagnostic, so that all this effort will be sustainable. And there is a big elephant in the room, is the political will. And if we have this vision of a world tomorrow, somebody was talking about Lassa fever as a neglected tropical disease for Africa. Yes, but then this should be a collective effort. The hub in Dakar is doing a lot of work. IROA is doing a lot of work, but we need to
all this collectively with the partners, with the community, of course, and all the people who are involved on health, but also on education. We have mentioned several times the training, the importance of the training. People all around West Africa need to know more about Lassa. The doctor, the nurse. There is an important effort here so that collectively we have the problem and collectively we want to tackle.
Excellent, very wise words, colleagues, participants. I think this will be the conclusion of this session. I think if there is something which is important here that we have discussed today, it's there are a lot of, remaining issues that we might need to tackle, but all very collectively. And not to have only a kind of, one dimension on one aspect. This is a kind of complex issue, and a complex issue need to be taken care of with a certain level of complexity. So you can see in this panel, you have social scientists, you have medical doctors, you have all of surveillance experts, and the coordination, the politics. So we all need to come together for addressing this issue. So it was really a great pleasure to have you here. I wanted to thank you again for your patience and for your participation to this session. And once again, thank you so much. Thank you, colleagues, for being around. Thank you. Merci beaucoup. Et très bon appétit. Colleagues will be around for the next 3 or 4 days. So please feel free to come and to talk to them and to exchange with them for enriching ourselves. Thank you. Merci. Do you need the...
mesdames, messieurs.
Allez, on va déchirer ça.
Non, mais d'accord. Je suis revenu. Tout le monde doit s'asseoir, s'il vous plaît. Mesdames et messieurs, je vous invite à bien vouloir vous tenir debout pour accueillir son Excellence, Monsieur le Premier ministre de Côte d'Ivoire, ainsi que la délégation de haut niveau qui l'accompagne. Ladies and gentlemen, you're kindly invited to stand to your feet and give a warm welcome to His Excellency, Mr. Minister, the Prime Minister of Côte d'Ivoire, and the ministers that are with him. Mesdames et messieurs, en général, l'accueil est plus chaleureux que ça. Je vous prie de bien vouloir ovationner.
pas un photographe, c'est bon.
Allô. Mesdames et messieurs, si vous m'écoutez en français, vous n'avez pas besoin de mettre vos casques, mais tout à l'heure, quand on passera à une autre langue, il va falloir prévoir les casques. Pour ceux qui sont déjà équipés de casques de traduction, ça sera 1 pour le français, 2 pour l'anglais et 3 pour le portugais. So it is 1 for English, channel 1 for French, channel 2 for English, and for Portuguese, channel 3. Thank you. Merci à nos amis de la presse.
Mesdames et messieurs, distingués invités, chers participants venus des 4 coins du monde, c'est avec une immense joie et une profonde fierté que je vous souhaite la bienvenue à la cérémonie d'ouverture de la 2e conférence internationale sur la fièvre de Lassa, organisée par l'Organisation ouest-africaine de la santé. Ce qui nous réunit ici aujourd'hui, c'est comprendre, partager et agir face à une maladie qui demeure un enjeu majeur de santé politique en Afrique de l'Ouest, mais aussi une préoccupation mondiale. La fièvre de Lassa, nous la connaissons, elle inquiète, elle interroge même. Mais face à elle, nous sommes plus forts. Nous avons la science, la coopération et surtout la volonté collective de protéger des vies. Je vous invite donc, avec enthousiasme et détermination, à entrer dans le cœur de cette conférence, à partager sans réserve vos connaissances et à bâtir ensemble des perspectives d'avenir. Bienvenue à cette rencontre d'exception, bienvenue à cette aventure humaine et scientifique, bienvenue à la 2e conférence internationale sur la fièvre de Lassa.
Ladies, gentlemen, welcome to this second Ecowas Lassa Fever International Conference. Experts from all over the world to work together to provide the best response to this Lassa fever, which is an issue of public health. Excellences, Monsieur le Premier ministre, Mesdames et Messieurs les ministres, Mesdames et Messieurs les personnalités des organisations nationales et internationales présentes ici même, nous sommes très heureux de vous accueillir à cette cérémonie. Tout de suite, nous allons avoir une série d'allocutions et nous aurons également une surprise artistique. Vous allez voir ce qu'on vous a préparé. Les allocutions seront marquées par la plus grande allocution, qui marquera la fin de cette cérémonie. Et les allocutions, ce seront celles de Monsieur le ministre de la Santé de Côte d'Ivoire. Puis nous écouterons en ligne la représentante de l'Organisation mondiale de la santé. Après quoi, nous donnerons la parole au ministre fédéral de la Santé du Nigeria avant de recevoir ici même son Excellence, Monsieur le Premier ministre de Côte d'Ivoire, pour l'allocution officielle.
Ladies and gentlemen, during this opening ceremony, we will have several speeches. Then there will be the official picture, and we will conclude with the ribbon cutting and a tour of the stands with the Prime Minister, His Excellency Mr. Robert Begré-Mambé. Let's invite on stage now for the first speech, the Minister of Health, Public Hygiene and Universal Health Coverage of the Republic of Côte d'Ivoire, His Excellency Mr. Pierre Demba.
Sous vos ovations, Mesdames et Messieurs, Monsieur le ministre de la Santé et de l'Hygiène publique de Côte d'Ivoire, Monsieur Pierre Ngou Demba.
Excellences, Monsieur le Premier ministre, ministre des Sports et du cadre de vie, Mesdames et Messieurs les ministres des pays frères, Monsieur le directeur général de l'Organisation ouest-africaine de la santé, Monsieur le représentant de l'Organisation mondiale de la santé en Côte d'Ivoire, Monsieur le représentant de l'Organisation mondiale pour l'alimentation et l'agriculture en Côte d'Ivoire, distingués experts, chercheurs et partenaires techniques et financiers, Mesdames et Messieurs les délégués des pays, illustres invités, chers amis de la presse, Mesdames et Messieurs, c'est avec une profonde reconnaissance et un sens aigu de responsabilité que je prends la parole à l'occasion de la deuxième conférence internationale de CEDEAO sur la fièvre de Lassa, ici à Abidjan, en terre hospitalière de Côte d'Ivoire. Il me plaît de prime abord de vous souhaiter, au nom du gouvernement, la traditionnelle Akwaba, c'est-à-dire la bienvenue à toutes et à tous à Abidjan, principalement à mes collègues, ministres venus des différents pays de la CEDEAO et les différentes personnalités qui ont bien voulu faire le déplacement d'Abidjan. Je voudrais vous adresser mes sincères remerciements pour votre présence massive à cette conférence qui témoigne de notre engagement collectif à lutter contre les menaces sanitaires que pèsent sur nos populations. Excellences, Monsieur le Premier ministre, distingués invités, Mesdames et Messieurs, le gouvernement ivoirien, à travers le ministère de la Santé, de l'Hygiène publique et de la couverture maladie universelle, en s'associant à l'organisation de cette conférence internationale sur la fièvre de Lassa, montre l'intérêt qu'il accorde à la recherche pour adresser cette problématique de santé publique. En effet, les travaux qui se tiendront durant ces 4 jours ici à Abidjan par les éminents experts sur la fièvre de Lassa devront être empreints de franchise, de rigueur scientifique et d'esprit de collaboration. Les recommandations qui en sortiront seront précieuses pour orienter les politiques nationales et régionales. Excellences, Monsieur le Premier ministre, distingués invités, Mesdames et Messieurs, le thème choisi pour cette seconde conférence internationale est intitulé « Au-delà des frontières, renforcer la coopération régionale pour lutter contre la fièvre de Lassa et les maladies infectieuses émergentes ». Ce thème vient en point nommé car il met en relief la question de la sécurité sanitaire dans notre sous-région. Ce thème sera abordé à travers plusieurs piliers, notamment la collaboration régionale et la surveillance transfrontalière, la surveillance de la riposte rapide, les innovations technologiques, y compris les vaccins, l'engagement communautaire et la stratégie de financement. Ces piliers sont essentiels pour poser les bases d'une lutte collective et renforcer contre la fièvre du Lassa et les autres fièvres hémorragiques. L'émergence rapide des maladies infectieuses, comme la fièvre de Lassa, tant chez l'homme que chez l'animal, montre la nécessité de renforcer la collaboration transfrontalière et multisectorielle. La Côte d'Ivoire, notre pays, bien que moins touchée historiquement, n'est pas à l'abri de cette épidémie. En effet, la fièvre de Lassa a été identifiée comme une menace sanitaire à haut risque à l'issue de la réalisation de la cartographie des risques sanitaires. En 2024, des flambées ont été enregistrées dans plusieurs États membres de la CEDEAO, causant des lourdes pertes humaines, économiques et sociales, illustrant bien la position de notre pays. Je forme donc le vœu que cette conférence permette de poser les jalons d'une stratégie régionale de lutte contre la fièvre de Lassa. Excellences, Monsieur le Premier ministre, honorables invités, Mesdames et Messieurs, en réponse à cette menace, ainsi qu'aux autres fièvres hémorragiques virales, l'État de Côte d'Ivoire, sous la très haute autorité de son Excellence M. Alassane Ouattara, président de la République de Côte d'Ivoire, et sous la conduite de M. le Premier ministre, ici présent, notre gouvernement a renforcé son dispositif de gestion des crises et menaces sanitaires à travers la mise en place des centres d'opération d'urgence dans les 10 pôles régionaux d'excellence de santé de notre pays. Ainsi, les capacités de préparation, de détection et de réponse aux urgences de santé publique, selon l'approche une seule santé, ont été améliorées dans nos différentes régions sanitaires. De plus, les progrès réalisés ont été objectivés par l'évaluation externe conjointe des capacités du règlement sanitaire international conduite en décembre 2023 avec la collaboration de l'OMS. Cette évaluation a mis en évidence les progrès considérables accomplis par le pays en matière de sécurité sanitaire et de réaction aux situations d'urgence de santé publique au cours de ces dernières années. Par ailleurs, un plan d'action national de sécurité nationale sur la période 2024-2028, adressant les mesures prioritaires pour combler les gaps relevés lors de l'évaluation, a été élaboré et est en cours de mise en œuvre. Excellences, Monsieur le Premier ministre, Mesdames et Messieurs, la présente conférence apportera certainement des réponses aux préoccupations de nos États sur la réduction des charges sociales associées à la fièvre de Lassa et nous aidera à prendre des mesures appropriées. Enfin, je voudrais réaffirmer l'engagement du gouvernement ivoirien sous la conduite de Monsieur le Premier ministre Robert Begré-Mambé, sous le leadership avéré de son Excellence Monsieur Alassane Ouattara, président de la République de Côte d'Ivoire, a contribué pleinement à la sécurité sanitaire régionale. Je ne saurais clore mes propos sans réitérer mes remerciements et félicitations à toutes les personnalités, à tous les partenaires qui nous accompagnent et à tous les acteurs qui ont pris une part active dans l'organisation de cette conférence. Je ne voudrais pas donc terminer sans témoigner toute ma gratitude à son Excellence, Monsieur le Premier ministre, qui nous a accompagnés de ses conseils et qui vient nous honorer de sa présence à l'occasion de l'ouverture de cette conférence. Veuillez applaudir, Monsieur le Premier ministre, s'il vous plaît. Monsieur le Premier ministre, éminent membre de l'OAS, illustre invité, pour ma part et au regard de l'expertise présente, je fonde beaucoup d'espoir sur les conclusions de vos travaux et j'en appelle à la mobilisation collective, à savoir les chercheurs, les décideurs, les partenaires techniques et financiers, pour que notre réponse soit à la hauteur de la réalité et nous permette un jour d'éliminer la fièvre du Lassa dans notre espace communautaire, et je peux vous dire que cela est possible. C'est sur cette note d'espoir que je voudrais donc vous souhaiter encore une fois la bienvenue en terre ivoirienne. Je vous remercie.
Monsieur le ministre de la Santé et de l'Hygiène publique de la République de Côte d'Ivoire, Monsieur Pierre Demba, qui vient de faire l'allocution de bienvenue et d'accueil ici. Mesdames et messieurs, il a rappelé l'espoir qu'il place dans les travaux qui vont se faire durant ces 4 journées. Salutations adressées à son Excellence, Monsieur le Premier ministre, ainsi qu'aux personnalités installées au premier rang. Alors, Tia, pour la suite, on n'aura pas forcément l'OMS. Hein?
Non, ce ne sera pas l'OMS, absolument pas, puisque nous allons, mesdames et messieurs, poursuivre avec une seconde allocution, celle de la commissaire à la santé, aux affaires humanitaires et au développement social de l'Union africaine, l'ambassadrice Ama Toum Amoa, qu'on va retrouver en ligne dans quelques instants.
Alors, vous avez annoncé qu'elle sera en ligne. Ambassador Excellency, are you online with us?
I'm online. Can I start?
Can you hear us?
Yes, I can.
We're not seeing you on the screen yet, I think.
Oh, you should see.
We are seeing you right
now.
I almost said right now, but we have to wait like 5 seconds more.
Sure.
And we can see you right now. Ladies, gentlemen, the High Commissioner for Health, Humanitarian Affairs, and Social Development, Ambassador Ama Amoa, you have the floor. Thank you.
Thank you very much. Thank you very much. Honorable President of Côte d'Ivoire, Honorable Minister of Health from Ecowas Member States, Director General of West African Health Organization, distinguished representatives of the World Health Organization, the World Bank, African Development Bank, the Coalition for Epidemic Preparedness, Innovations, and other valued partners. Distinguished guests, ladies and gentlemen, it is an honor to join you virtually at the second Ecowas Lassa International Conference, convened under the inspiring theme, Beyond Borders, Strengthening Regional Cooperation to Combat Lassa Fever and emerging infectious diseases in Abidjan, Côte d'Ivoire. Lassa fever remains a public health threat across the region. It is not only a clinical challenge, but a complex socio-ecological threat demanding a multi-sectorial response. The World Health Organization estimates between 100,000 and 300,000 infections each year, with approximately 5,000 lives lost. Nigeria bears the greatest burden, with recent reports indicating Lassa fever remains a persistent public health challenge in the country, with annual outbreaks expanding across the country. Between 2018 and 2023, the disease spread from 20 to 34 of Nigeria's 37 states, underscoring its endemic nature. Recent data from the Nigeria Center for Disease Control and Prevention indicates 1,171 suspected cases, 290 confirmed cases, and 53 deaths between 1st and 26th January 2025, with a case fatality rate of 18.3%. Lassa fever transmission is highly seasonal, peaking during the dry months when food scarcity drives rodent-human interaction. Outbreaks continue to affect Benin, Ghana, Guinea, Liberia, and Sierra Leone. For survivors, almost a third are left with hearing loss, a lifelong disability that devastates families and communities. And still, there is no licensed vaccine and no approved antiviral medicine. Yet, we must not be disheartened. Africa is making progress. The Africa Centers for Disease Control and Prevention has prioritized Lassa fever and is investing in stronger laboratories, surveillance, and training. Promising vaccine trials are underway. African scientists at the forefront. The Africa Medicines Agency, though not yet fully operational, holds great promise. Once functional, it will provide the continent with the means to harmonize regulatory systems, accelerate approval of new vaccines and treatments, and guarantee equitable access for all Africans. The African Union is determined to build on this progress. We are committed to advancing research and innovation, ensuring that African institutions and scientists play a central role in the development of vaccines, therapeutics, and diagnostics. We are deepening One Health approaches that link human, animal, and environmental health, recognizing that the drivers of Lassa fever demand solutions beyond the health sector alone. And we are mobilizing, working to secure African access to the pandemic fund and other mechanisms to strengthen laboratories, supply chain, and emergency responses. But no single institution can overcome this challenge in isolation. Stronger AU-ECOWAS collaboration is essential. Together, we can link national and regional surveillance systems with Africa CDC to ensure that outbreaks are detected and contained quickly. We can align regulatory frameworks with WHO so that once Africa Medicines Agency is fully operational, West Africa will be among the first to benefit. We can pool resources to build the laboratories, workforce, and stockpiles needed to withstand future epidemics. Excellency, Lassa fever does not respect borders. Neither must our response. It is only through solidarity between our states, between our regional bodies, and with our global partners that we can protect lives, strengthen health security, and prepare for the threat of tomorrow. Let this conference be a milestone. Let us ensure that the outcomes and recommendations shared here translate into action. Policy decisions should be driven by evidence, and that the unity of purpose we demonstrate today ensures and endures beyond these 4 days in Abidjan. I thank the government of Cote d'Ivoire for hosting this timely meeting, Wahoo for convening this gathering, and our partners for their steadfast commitment. Above all, I salute the health workers and researchers whose courage and dedication remain the bedrock of our fight. Together, through AU Ecowas partnership, we can reduce the toll of Lassa fever, build resilient systems, and move closer to a healthier, stronger Africa. Thank you very much. Merci beaucoup.
Merci beaucoup. Excellency Ambassador Amatoum Amoa, thank you for this speech. And she said something, Lassa fever has no border. Thank you.
Alors, nous voulons remercier toutes ces délégations qui sont venues ici à Abidjan pour participer à cette grande conférence internationale. Nous voulons remercier les différents ministres de la Santé du Nigeria, du Sénégal, de la Gambie, de la Guinée-Bissau et de la Côte d'Ivoire, bien sûr, les différents Deputy Ministers of Health du Libéria, du Ghana ou encore de la Sierra Leone, sans oublier les représentants d'autres pays. On pense évidemment à la délégation du Bénin, on pense à la délégation qui nous vient du Mali ou encore du Cap-Vert, et puis ces différents groupes, ces différentes organisations qui nous font également l'honneur et le plaisir d'assister à cette conférence. Un coucou particulier à l'Institut Pasteur de Dakar, à l'Organisation mondiale de la santé, l'Organisation La Vie, l'IFC ou encore WHO.
À la suite de Tia, je voudrais faire une mention spéciale à une délégation. Je vais leur parler en français, donc j'espère que les traducteurs marchent correctement. Je voudrais saluer la forte délégation du Nigeria, mesdames et messieurs. Est-ce qu'ils sont là? Nigeria. We want to see Nigeria. Where is Nigeria? I told you. I told you. Je vous avais dit. Très forte délégation du Nigeria. Thank you to be here. Merci infiniment. Très, très forte délégation du Nigeria. Et justement, avec cette présentation de la grande famille nigériane qui est avec nous, j'ai le plaisir d'introduire ici, pour son allocution, le ministre de la Santé, non, le ministre, oui, c'est ça, de la Santé et des Affaires sociales de la République fédérale du Nigeria. Il s'agit du docteur Paté.
Absolutely. Let's welcome on stage the Coordinating Minister of Health and Social Welfare of the Federal Republic of Nigeria, His Excellency Dr. Muhammad Ali Paté.
His Excellency Muhammad Ali Paté.
Thank you. His Excellency, the Prime Minister of the Republic of Cote d'Ivoire, the Honorable Minister, my dear friend and brother, Minister of Health and Public Health of the Republic of Cote d'Ivoire, my dear brothers, the honorable ministers here present from all the ECOWAS countries and the deputy ministers, the Director General of the West African Health Organization, representatives from World Health Organization, our partners, CEPI, the EAV, and several other bilateral partners, senior government officials, and of course, my colleagues from Nigeria, the esteemed Nigerian delegation that is here as well. It is indeed a great privilege to stand before you in this beautiful city of Abidjan for the ECOWAS Second Lassa Fever International Conference. And I begin by expressing profound appreciation to the government and people of the Republic of Cote d'Ivoire for their warm hospitality and for hosting this important meeting. On behalf of myself, our government, but also all the Nigerian delegation that is here, we thank you, Your Excellency, Honorable Minister, for the warmth with which we were all received. I also commend the West African Health Organization, our development partners, and all participating member states for their unwavering commitment to tackling one of the region's persistent public health challenges. And this gathering marks an important milestone in our collective effort to address one of the most pressing and persistent and challenging public health threats that is particular to our West African sub-region. Lassa fever, which was discovered in Lassa in northeastern Nigeria, has continued to claim lives for the last several decades since its discovery. It has strained our health systems, attacked our health workers, threatened regional health security. Its complex epidemiology and recurrent outbreaks remind us that no single country can tackle it alone. It requires a united, coordinated, and sustained response. This year's theme, Beyond Borders, strengthen regional cooperation to combat Lassa fever and emerging infectious diseases, speaks directly to the reality that we face. It was mentioned by the AU Commissioner that Lassa fever does not respect regional boundaries or national boundaries, and neither do other emerging infectious diseases. Our strength lies in the unity of our responses, in the willingness of our nations to work together, to share knowledge, and to coordinate resources to protect the health of our people. Across West Africa, Lassa fever continues to pose serious threats to lives, livelihoods, and health systems. Nigeria, like several of our neighbors, has borne a significant share of the burden, with outbreaks affecting multiple states each year. The human cost is considerable, and the socio-economic impact is equally profound. Yet, this disease is not confined only in our country, making necessity for us to work collectively. And this is not only strategic, but it is imperative, it's urgent. And in Nigeria, our ongoing national efforts includes expanding our laboratory networks, training our frontline health workers, improving our case management, case detection, reinforcing community awareness and our community systems. However, we recognize that national action must be complemented by strong regional collaboration, where data flows freely, research outcomes inform our policies, and that our collective preparedness grows stronger. Earlier today, we had the ministerial roundtable to discuss how we can collectively push for a vaccine over time that can help us prevent this disease. So this conference offers a timely platform for all of us, and I urge all the scientists, the civil society organizations to really lean in to advocate. Not only do we need to strengthen our national health systems, improve our primary health care, build our frontline workers, engage our communities, but importantly, to foster the research and development and innovation, to foster the development of diagnostic tools and vaccines, because ultimately, this disease is local to us. The solution is not going to primarily come from global. It is our problem. It is us that will rise up to invest, to mobilize our friends from the region and globally to find solution to our local problem. That is very important. And as we begin this conference, I urge us to focus all on actionable steps, outcomes, practical measures that will strengthen our resilience, protect our populations, and pave the way forward for the eventual elimination of Lassa fever as a public health threat in West Africa. It is possible if we take the long view, if there are diagnostics and there are vaccines developed long-term, we could get this out. But if we stay and be complacent, then this threat will be with us for a long time. On behalf of the federal government of Nigeria, I reaffirm our commitment to working side by side with all our Ecowas brothers and sisters under the leadership of the West African Health Organization to achieve a healthier, safer, and more prosperous region. And I assure our development partners from all over the world to stand by us, to work with us, and to achieve this strengthened regional health security, which is important for the world. I wish you all fruitful discussions and a successful conference. Thank you very much.
Excellency Dr. Muhammad Ali Pate, Coordinating Minister in charge of Health of the Republic of Nigeria. And of course, he talked about shared knowledge, coordinating resources, data to flow freely. And of course, he made an advocacy on a platform to actually work towards a vaccine against Lassa fever.
Voilà, merci à la presse. Voilà, on vous a donné quelques instants pour prendre les photos. Vous en aurez d'autres tout à l'heure, ne vous inquiétez pas. Voilà, merci. On va pouvoir continuer notre conférence. Alors, on va passer aux réjouissances maintenant.
We're going to have singing and dancing break, and Tia will tell you more about what's coming.
Absolument. On a vu que la délégation nigériane est très nombreuse ce soir. Eh bien, nous allons vous proposer d'accueillir avec une salle d'applaudissements un groupe de danse traditionnelle Yoruba appelé Kappa White Dance. Ils nous viennent tout droit du Nigeria. Leur danse exprime la paix, la joie et l'amour. Merci d'applaudir très fort le groupe Omo Bori Owo.
Oh, ladies and gentlemen. Don't worry, they're coming, but they're just taking their time.
J'ai eu peur qu'on ait à occuper la scène et esquisser quelques pas de danse le temps qu'ils arrivent.
We will not do it. I think if we put our hands together, maybe they will come faster.
Merci. On salue le Premier ministre, papa. Comme chez nous, les Yoruba, quand on veut saluer les grandes personnes, on se prosterne pour saluer les grandes personnes. Donc, papa, Premier ministre, on vous salue, bonsoir. Awala la sawa, awala la sawa, Emma Bawawi. Awala la sa, Emma Bawawi. Emma Bawawi. Tó bá jẹ́ tijó, tó bá jẹ́ torí, Emma Bawawi. Emma Bawawi. Emma Bawawi. Emma Bawawi. Àyájọ́ ọjọ́ kan lèní jẹ́ tá a fi ń rántí ibi tán bí wa. Béwúrẹ́ jẹ lọ á padà wálé, bàgùtàn jẹ lọ adẹ́yìnbọ̀, àjẹwẹ̀yìn ló bẹ̀rẹ̀ dẹ̀ jẹ́. Kárọ́tì ilé níbi wọ́n bí wa.
Àyájọ́ ọjọ́ kan lòní jẹ́ tá a fi ń rántí ibi tán bí wa. Béwúrẹ́ jẹ lọ á padà wálé, bàgùtàn jẹ lọ àjẹwẹ̀yìn ló bẹ̀rẹ̀ dẹ̀ jẹ́. Kárọ́tì ilé ibi wọ́n bí wa.
Ẹni tó dúró ẹ kú ìdúró, èrò ìjókòó ẹ kú ìkàlẹ̀, akọkùnrin àṣìtúnkọbìnrin, ṣàlàfíà lẹwà ilé ńkọ́ o, gbogbo yín là kí. Gbogbo yín là kí. Ìjọ lè rí gbọ́ lè rí jọ̀wọ́ gbó, ìjọ lẹ̀fà gbọ́ lẹ̀fà jọ̀wọ́ dà. Ìlú làwọn agbọ́dọ̀ tẹ́wọ́ jó, àjọfàlára wọn fún wa lọ́wọ́, àjọfàjèrè wọn fún wa lọ́mọ, àjọfọ̀ràngún wọn fún wa lọ́wọ́. Owó ọ̀hún lọ irọ́ ṣẹ̀kẹ̀rẹ̀, ó wá di ijó ọlọ́ba.
Ṣẹ̀kẹ̀rẹ̀ wọ́wọ́.
Ó di ijó ọlọ́ba.
Ṣẹ̀kẹ̀rẹ̀ wọ́wọ́.
Ṣẹ̀kẹ̀rẹ̀ lọ́ba jó wọlé, lọ́ba jó jáde.
Ṣẹ̀kẹ̀rẹ̀ wọ́wọ́.
Ó di ijó ọlọ́ba.
Ṣẹ̀kẹ̀rẹ̀ wọ́wọ́.
Àló di ijó ọlọ́ba.
Ṣẹ̀kẹ̀rẹ̀ wọ́wọ́.
Ó di ijó ọlọ́ba.
Wọ́wọ́.
Ó di ijó ọlọ́ba.
c'est douce.
Africa, 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 Baba Pate. Ṣebí bàbá tiwa lónìí ilẹ̀. Pate, Pate, bàbá wa Muhammed, ọmọ Pate, bàbá wa Muhammed, ọmọ Pate. Wọ́rọ̀, wọ́rọ̀. Que la paix et l'amour, que la paix et l'amour règnent sur la Côte d'Ivoire, notre pays d'hospitalité, notre pays d'amour, de la cohésion sociale. Que toute l'Afrique célèbre, que toute l'Afrique célèbre la joie, la paix, que les maladies nous épargnent.
Merci. Omie, Borie, Omo, Borie, Omo.
C'est douce.
Now, I believe, thank you so much. I believe some of you may think that they are coming from Nigeria or from Benin. They are living here with us. Yes. Yes. African unity, they are here. Thank you so much. Tia, what's coming next?
Alors, on va quand même faire la parité des choses, hein, si tu veux bien, mon cher Stéphane.
Pourquoi pas?
Ben oui, on est allé au Nigeria. Eh bien, revenons un petit peu chez nous avec ce groupe de danse Akan. Pour ceux qui ne savent pas, c'est un groupe donc, de danse traditionnelle. La culture Akan, c'est une culture propre de chez nous et on partage cette culture également avec le Ghana. C'est un groupe de danse royal qui valorise la pensée qu'il suit. Eh bien, je vous propose de les applaudir très très fort jusqu'à ce qu'ils arrivent ici sur scène. Et vous savez que le premier salaire de l'artiste, ce sont les applaudissements. Alors, on peut faire encore mieux que ça, mesdames et messieurs.
Thank you. Okay. I wanted to make sure the platform was strong. I think it's strong enough. Thank you.
Obrepon, Obrepon, Titi, Pia Krokro, Uye, Susuka Kraka, Etiwa Chia, Tuturobesa, Sokra, Sokete Kra, Sokrapa, Sokra Krokro. Monsieur le ministre, à quoi pas? Monsieur le ministre,
Ayabema, 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 bema, yabema, nana, yabema, yenkwe, origo, So,
Wow, Titi. Avant que vous partiez, ce tam-tam là, ça parle vraiment? Quand vous tapez, veut dire quelque chose? Ok, wonderful. Ladies and gentlemen, thank you to Titi.
Allez, un tonnerre d'applaudissements, s'il vous plaît. Merci beaucoup. Alors, nous allons pouvoir continuer cette belle cérémonie. Avec quoi?
Avec aussi un groupe qui était avec nous dans la salle depuis longtemps. On ne les a pas salués et ce serait intéressant, Tia.
Absolument. Je voudrais qu'on applaudisse très, très fort ceux qui nous entretiennent également depuis tout à l'heure. Les compagnons du Sacan, s'il vous plaît.
Ladies, gentlemen, it's time now to receive here on this platform our Prime Minister for the opening speech. Tia.
Merci d'accueillir sur scène le Premier ministre, Monsieur le Premier ministre, chef du gouvernement de la République de Côte d'Ivoire, son Excellence, Monsieur Robert Begré-Mambé.
Sous vos ovations, mesdames et messieurs.
Prenez place, s'il vous plaît. Mesdames et messieurs les ministres, Monsieur le directeur général de l'Organisation ouest-africaine de la santé, Monsieur le représentant de l'Organisation mondiale de la santé en Côte d'Ivoire, Monsieur le représentant de l'Organisation mondiale pour l'alimentation et l'agriculture en Côte d'Ivoire, chers partenaires techniques et financiers, Mesdames et Messieurs les délégués venus des différents pays, chers amis experts, illustres invités, chers amis de la presse, mes frères et mes sœurs venus des différents pays. Je voudrais vous dire que je suis très impressionné par le nombre de participants à cette grande et belle conférence. C'est pourquoi je mesure l'importance de cette conférence internationale organisée par la CEDEAO sur la fièvre de Lassa. Je voudrais à cet effet traduire au nom du président de la République, Son Excellence Alassane Ouattara, la profonde reconnaissance de l'État de Côte d'Ivoire à la CEDEAO d'avoir choisi Abidjan pour abriter cette grande activité. Je voudrais également souhaiter à tous les participants venus de toutes les régions du continent le traditionnel Akwaba, c'est-à-dire bienvenue en terre ivoirienne. Et je voudrais que nos frères et sœurs ivoiriens ici acclament la présence de tous nos invités. La Côte d'Ivoire est heureuse de contribuer activement à la sécurité sanitaire régionale et mondiale à travers la promotion des initiatives internationales et régionales. La récurrence des épidémies de maladies infectieuses comme la fièvre de Lassa, la maladie à virus Ebola, la variole du singe et le choléra dans l'espace CEDEAO constituent un lourd fardeau social et économique pour les populations et une entrave à la sécurité sanitaire de notre sous-région. Malgré les efforts des États, les populations continuent de payer un lourd tribut aux épidémies en termes de morbidité, de mortalité et de handicap. En avril 2025, plus de 65 épidémies ont été enregistrées sur notre continent, dont le choléra a occasionné plus de 6 000 décès. Chaque année, en Afrique de l'Ouest, la fièvre de Lassa est responsable de près de 300 000 infections, dont 5 000 décès. Face à ces situations, nous avons obligation d'agir avec vigueur et rigueur pour protéger la santé de nos populations et leur assurer un bien-être. À cet égard, plusieurs initiatives en cours méritent d'être renforcées. Celles-ci sont conduites par les États et l'Organisation ouest-africaine de la santé et s'inscrivent dans les cadres d'approche sous-régionale et régionale. Il s'agit notamment de la prévention, de la préparation et de la riposte à ces épidémies. Ainsi, l'Organisation ouest-africaine de la santé s'implique activement dans la gestion des menaces et crises sanitaires qui surviennent dans notre espace CEDEAO à travers plusieurs stratégies, dont celle qui nous réunit ce jour. Honorables invités, mes frères et mes sœurs, je voudrais adresser mes félicitations à l'Organisation ouest-africaine de la santé pour les actions et l'assistance technique qu'elle apporte aux services compétents de nos États dans la lutte face aux urgences sanitaires, et ce, malgré la rareté des ressources financières mobilisables. La présente conférence, qui a pour thème, et je cite, « Au-delà des frontières, renforcer la coopération régionale pour lutter contre la fièvre de Lassa et les maladies infectieuses émergentes ». Cette conférence est une excellente initiative de l'Organisation ouest-africaine de la santé et une occasion pour approfondir la réflexion sur la sécurité sanitaire liée aux maladies émergentes dans l'espace CEDEAO. C'est pourquoi je salue à cet égard la présence distinguée de tous les experts et chercheurs qui auront à débattre, à échanger et surtout à proposer des solutions aux décideurs afin de réduire et apaiser les souffrances de nos populations du fait de la fièvre de Lassa et des autres maladies émergentes. Pour ma part, je reste convaincu qu'il nous faut un nouveau langage, une nouvelle vision qui repose essentiellement sur la prévention et l'atténuation des risques. Chers frères et sœurs, distingués invités, la coopération et la solidarité régionale doivent être le socle de la lutte contre les maladies dites émergentes. C'est pourquoi, face à la fièvre de Lassa ou toute autre maladie émergente, chaque État de notre espace doit bénéficier du soutien multiforme des États voisins, car les virus et les maladies n'ont pas de frontières. Nous devons toujours avoir à l'esprit qu'une épidémie localisée dans un pays de l'espace CEDEAO est une épidémie potentielle, car elle peut se propager dans tout l'espace. Par conséquent, les efforts des États doivent aller ensemble pour contenir les épidémies à la source afin d'éviter leur propagation. C'est cette marque de coopération et de solidarité qui doit guider nos actions au sein de l'espace CEDEAO. Je voudrais, à cette tribune, affirmer à nouveau l'engagement de la Côte d'Ivoire à soutenir toutes les initiatives qui visent à améliorer la sécurité sanitaire dans l'espace CEDEAO et à s'investir pleinement dans le renforcement de la coopération sous-régionale. Distingués participants, mesdames et messieurs, chers frères et sœurs, je voudrais, avant de conclure mes propos, vous réitérer les vifs remerciements de la Côte d'Ivoire, notamment à l'Organisation mondiale de la santé, au CDC Afrique ainsi que tous les partenaires techniques et financiers qui ont contribué à l'organisation de cette grande et belle conférence. Je félicite tout particulièrement l'Organisation ouest-africaine de la santé pour ses actions qui visent à prévenir et à éradiquer les épidémies dans notre sous-région. Je souhaite que la conférence d'Abidjan soit une parfaite réussite et que cette conférence permette de soumettre aux décideurs des solutions concrètes. Parmi ces solutions, il y a la prévention, l'hygiène domestique, la lutte contre la présence des rongeurs à proximité de nos domiciles et à proximité de nos habitations. Je voudrais dire en terminant que individuellement, les pays peuvent bien faire individuellement, mais collectivement, les pays peuvent devenir excellents. Il y a une différence. Bien faire et être excellent. C'est sur cette conviction que je voudrais souhaiter d'excellents travaux et je déclare ouverte la deuxième conférence internationale sur la fièvre de Lassa. Je vous remercie.
Mesdames et messieurs, allocution officielle de son Excellence, Monsieur le Premier ministre de Côte d'Ivoire, chef du gouvernement, ministre des Sports et du Cadre de vie.
Voilà, nous allons appeler tous les officiels.
Pour la photo de famille.
Alors, voilà, autour de Monsieur le Premier ministre, nous avons Monsieur le ministre de la Santé, Yardemba. Nous allons appeler les ministres des délégations venus de l'étranger. Nous allons appeler les responsables de l'OMS, les responsables de la CEDEAO, Monsieur l'ambassadeur de l'Allemagne, et puis le directeur général de l'Organisation mondiale de la santé, s'il vous plaît.
Et pour revenir sur les termes de son Excellence, Monsieur le Premier ministre, individuellement, les États peuvent bien faire, mais ensemble, ils deviennent excellents. Il y a une différence. Merci, Excellence, Monsieur le Premier ministre. Juste vérifier qu'on est bon avec les photographes et rappeler que juste après, on va demander aux participants de bien vouloir rester sur place et de permettre à Monsieur le Premier ministre ainsi que la délégation de haut niveau qui l'accompagne de sortir en premier pour l'ouverture officielle des stands, Tia.
Absolument. Et pendant que les photographes immortalisent ce moment, eh bien, nous tenons à remercier tous ceux qui ont participé à cette belle cérémonie d'ouverture de cette conférence internationale sur la fièvre de Lassa. On pense évidemment aux partenaires, on pense à tous ces illustres invités, aux chercheurs et à chacun d'entre vous. Merci pour votre présence et pour votre engagement.
Merci infiniment. Et comme l'ont dit tous les officiels, Abidjan est heureux de vous accueillir pour cette deuxième conférence. Tout de suite, mesdames et messieurs, la coupure du ruban officiel par son Excellence, Monsieur le Premier ministre, et la visite des stands.
Alors, on va essayer d'y aller progressivement. Une fois que les officiels seront passés, je vous propose d'y aller rang par rang, voilà, pour pouvoir visiter les stands qui vous sont proposés par l'organisation de cette conférence internationale.
Et puis, bien sûr, juste après encore, on aura des travaux. Et puis, tous les experts réunis plancheront sur comment apporter une réponse efficace à la fièvre de Lassa. Pour moi, j'ai été heureux de présenter cette cérémonie d'ouverture avec toi, Tia.
Merci beaucoup, Stéphane.
Merci.
Merci à tous.
À bientôt.
Yes, no, he will give you the floor. Prof, you are going to give the keynote on the third. C'est ce qu'il voulait, quoi.
Allô, 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 allô. Mesdames et messieurs, Excellences, mesdames et messieurs, distingués invités, en vos rangs, grades et qualités, je voudrais vous inviter à reprendre vos places, s'il vous plaît, pour la suite des travaux. Chers participants, distingués invités, s'il vous plaît, veuillez reprendre vos places, s'il vous plaît, pour la suite de cette conférence internationale de la CEDEAO sur la fièvre de Lassa. Pour la suite des travaux, je voudrais ici ainsi inviter le professeur Tomori qui viendra nous faire une présentation introductive sur les différents progrès, défis et opportunités pour la région de la CEDEAO en ce qui concerne la lutte contre la fièvre de Lassa. I would like to invite here Professor Tomori. Professor Tomori, please. Merci de l'applaudir, merci de l'encourager, justement. For the keynote address on the Lassa fever, progress, challenges, and opportunities for the Ecowas region. Thank you so much, Professor. The floor is yours. Thank you.
Thank you very much. Good afternoon, ladies and gentlemen. It's a very unique opportunity for me to be here. I'm just trying to see how that works. Okay, can you just, okay. So thank you very much for this opportunity. I've been hearing about Lassa fever since 1969, when it first occurred. And I was a student at the university when the team that investigated that outbreak visited my university and gave a talk to the virology class. Ever since then, I've been tied to Lassa fever. And if I'm looking tired today, it's because I'm tired of over 50 years ago hearing the same story, and we don't seem to be making too much progress. It is quite, for those, if you've been that, you can see the weight on it. So I'm going to quickly go through and talk to you. If my eyes, this used to be okay for me when I was young. I could see through the wall, but now I can't even see my face. So I'll be looking quickly at some kind of introduction, looking at the background of Lassa fever in West Africa, considering the first meeting that was held in Lagos. What happened between that time? Why are we here? Happy with what we are. Can we have the next slide, please? Okay. So Lassa fever needs no introduction, as I'm just trying to say. That probably they've been lying around this area long time ago, before it was first discovered in Nigeria in 1969. It's a viral infection. You know all that. So let me not waste your time. Next slide. Let me not waste your time on all those stories. Next slide, please. That's what, you see the corner there, that's the Lassa town. The first patient was carried out from there, that distance, almost to 26 hours, to get that patient from Lassa to Jos. Next slide. The next slide, we see that it's all across West Africa. The blues are where it's endemic. The other ones were occasionally reported, not often. Next slide. Can you be as fast as I talk? Thank you. These are evidence to show that Lassa fever have been here long before we started talking about that. I remember particularly leading in Zonko, a missionary who was in Nigeria in 1952. After she left, she never came back. In 1970, 78, when we were looking for, they tested her serum, and she was positive for Lassa. Next slide. I think you are too slow for me. So it costs estimated 100,000. You know all those ones. Even the minister knows that. So there's no need me telling you all that. Then we had a problem in 2018 in Nigeria when we thought that was the less number of Lassa fever cases. Next slide. I'll be telling you before I finish my sentence so that you can catch up with me. Next slide. Maybe I should be using my own. So in 2018, Nigeria experienced, okay, maybe it's better. And at that time of that discovery, we thought, that was the biggest we'll ever had. We're not going to have anything like it. So we decided 2019, it was 50 years celebration. I hate to use the word celebration because you don't celebrate death. Occasion to remember it. Well, like I always know that when you have this type of thing like this, there are always two groups of people. There are the celebrants who celebrate the thing, and there are the cerebrants who think after the meeting has gone, what do we do with it? So the celebrants have gone. Now the cerebrants are here to hear. But sometimes I think we make a mistake in not letting the celebrants sit down to us while we're talking these things. Because you go, they talk, the radio, TV catches them, and they're gone. And then they leave the problem for us. And they are the ones who have the solution to the problem. But then what happens? So, however, the celebrants and the cerebrants, there are two different groups of people. One celebrates, the other thinks about what to do about it. So, when in 2018, we thought Lassa, that was the greatest we had. Then 2019 came. We had more than we had in 2018. And since then, if you look at that graph, we've been having large number of cases, suspected cases, reported in Nigeria all over the years. If you start that deep in 2021 or so, that was because of COVID. Or as soon as COVID left, Lassa came back. And the figure for this year is just up to this time. I'm sure it's going to be much, much, much higher than that. I wanted to make this a kind of group discussion with us so that we can look at it. Back then, when our colleagues were there at that time, when they did it, again, as I said, allow me to stay here so I can properly read what I'm doing. So the first Lassa Fever International Conference took place in Nigeria in January 2019. The purpose was to reflect on these 5 years of Lassa fever, share our lessons, from Nigeria, identify those gaps and those areas and set priorities for future trials, then formulate prevention and control activity. One of the things about the 2018 adview was that at that time we had 633 confirmed cases in all the states of Nigeria, 27% case fatality, and that was really the thing that got us. The Institute of the Institute at Irua State University, State Hospital, was the one that did most of the diagnosis at that time. Sorry, I have to keep remembering to use this. Is it coming? Okay. So then that group came up and decided, look at the case management. Acute kidney infection was in 40% of the pediatric cases. The detected virus in the breast milk. Retinal hemorrhage was a diagnostic marker at that time. And ribavirin was really quite ineffective for hearing loss. So we knew we had problems. Animal experimentation, rodent control trials were done in Sierra Leone. We found that climate change also affected this because increased rodents moving into the houses, increasing the contact between man and man. It was considered that bushmeat was identified as an exposure rate. I must make mention of this one. But then you cook that bushmeat, there's no Lassa virus there. The danger is in when they catch those raw animals and they were treating it, and the women at home are treating cooking. That's where the danger is. But sometimes the message we get out is very wrong. Say, don't eat bushmeat. The message is for those who are actually trapping those ramen. I think these are one of the things that we do with our science, that we never give the right, correct advice to our people. So the diagnostics was, they use the dual RT axis for all of the different lineages of Lassa. By using real-time genomics, they are able to track the kind of where parts of the world it was. And then with metagenomics, they revealed that apart from Lassa, there was other co-infections that come with us. And the issue of vaccine, we didn't really think much of vaccine at that time, but they're all in the development. Monoclonal antibodies were being used for effective treatment, and then other levels of things were being done. So what are the next steps? At that meeting, it was decided that 4 things we needed to do. One was to launch an adaptive clinical trial. The second was to strengthen our surveillance and diagnostic, expand the One Health and community intervention, because as we had, there's no way you can deal with Lassa on one side alone. And then ensure equitable access to vaccines and for treatment. So what have we done since then? But more importantly, what has Lassa treated us? What have we done with it? And how has it handled us? Those are the questions we got. I mentioned something about the selection and the celebrants. The celebrants are on this side. The celebrants, we are actually working. You can see them there. Those are the people, the Institute in Nigeria, Ecowas, Israel, especially and SEPI, and other people who, after all of the talk, decided that we need to do something. They were the brains that were doing what needed to be done. I think I've not. Okay. So what did Lassa do to us? Let me use Nigeria as an example, because when you hear the figures from other countries, it is, they're not like what happened. That's the graph we're talking about. The arrow there is showing you 50 years of discovery of Lassa fever. It was in 2018 we had this number of suspected cases, 3,000. We thought the world has come to an end. But by the end of 2019, at that, it had doubled. And it kept going on. Then COVID came, it dropped in, can I use this as a pointer? No, I don't think so. So you can see in the year 2021, the number, not because of anything, but because COVID took over. But thereafter, as soon as COVID left, the numbers kept increasing. As of last year, we had at least 10,000 suspected cases. We already gotten 7,000 reported this year as of the week 33 of epidemiology. The red line at the bottom is showing you the number of cases that were confirmed. I'm going to be talking about this also, because this is one of the things that we need to be considering. As you are scientists, I think it's important to take note of that. At the bottom is the blue, which is showing you the death cases. Okay. One of the things that if you look at the number of the confirmed Lassa fever cases and death, the death is showing in the red in case of case fatality rate, and while the yellow is showing you the same figures. But this time we're looking at cases that were reported. But you notice one thing, we had a big problem in 2017 when the case fatality rate was as high as 39%, where something happened. But then you can see the number hasn't gone yet. But we thought we were going to go down to single-digit level for CFR, but we've not reached that yet. We're still working and still having this type of thing. Ecowas gave us that figure about what Nigeria has 747. That's as of this for the first 6 months of this year. Nigeria 747, Liberia 9, Guinea 2, and Sierra Leone 9. But again, it is not a Nigerian problem alone. But you must also remember, when you look at these figures, look at the population we are talking about. 747 to 250 million. If you actually pro-rata it, you probably find that there are more problems in those other countries with lower population than this. So what did the celebrants do? Those are the people who made up their mind that something must be done. I've listed them there, SEPI and other areas who are helping us. We have the institute in Irua. We have WAHO itself, and of course the NCDC in Nigeria. Those are the ones. So these are the 4 things they agreed upon. The first was we should launch an adaptive clinical trial. And you see studies have been done. Already, Irua in NU 1.5 study in Nigeria is investigating Lassa incidents to give you baseline data so that when we have the vaccine, we have information that we can use to monitor the disease. The data will support the development of an effective Lassa fever vaccine, while community engagement, it was a major part of this enable program that they're doing. Now, the Lassa vaccine, that's one of the things that the WAHO and Lassa Fever Coalition are doing. Pre-clinical trials in non-human primates show that this is a very good vaccine. Phase 1 trials to assess the safety, immunity, and different concentration will be going on among the children, people between the age of 18 and 50 years. The other one was the integrated drug trial, which is multinational, multi-center control and randomized, and it's taking place a 5-year program being coordinated by Alima with our friends in BNI, ISCH, and Federal Medical Center, OWO. The goal is to determine whether these investigation regimens outperform ribavirin in preventing death. Other West African countries will still join in this study. Now, one of the challenges about Lassa vaccine is the Lassa virus itself. Its genetic diversity is so high, it's so many and so significant. And the classification of the virus is not even complete. And then who do we include? Usually we take pregnant women and children out of the study we're doing. And when you look at the population of countries, we have more children, and in some very good countries, they have more pregnant women than human beings there. So that's the kind of problem we have. So all these are issues that we need to. So the other one was the fact that these are other challenges that we call. CEPI and others, AIVA, others are funding what is happening. And you see, one of the things I was a bit unhappy about was that you allowed the ministers to go, because they won't hear this type of thing. And they should be the one to hear them. They are the ones who are creating problems for us. And I would have told them if they were here, but you didn't give me the opportunity. You are hearing it, you can't do anything about it, but you're not the minister. In terms of demand forecasting, we don't even know how much we need. So how much vaccines you need? You need these ones to guide those who are making the vaccines, in the kind of situation that we're having. I think I didn't press hard, Okay. CEPI came up with this, that over a 10-year period, in 15 countries, we will save 3,300 lives and save this amount of money. I'll talk about that later, And I want to say thanks to all those who have been involved in all these studies, Ecowas, WAHO, CEPI, colleague researchers, all of you are sitting down here. You are the one making the difference in Ghana, in this country, and other places. So the second one was that we need to strengthen surveillance and diagnostics. And what have been the situation? Current diagnostic methods for Lassa fever include the following things. I'm not going to go through this quickly so that you know them already. And that PCR detects virus directly. You need advanced lab and skilled staff, to get all these things done. There's no molecular technique detection. There are ongoing efforts to develop the rapid diagnosis technique. I was listening to some of my colleagues at the back there talking about RDTs, what have been the experience. But I think we have one, but it's not yet approved for studies. Now, we are really probably no better than where we were in 2019 at the time of the first conference. And what do I mean by that? Before you drag me out of this place, let me tell you what I'm talking about. So look at that picture again. The numbers are increasing every year. And the detection rate is still the same. I mean, you can see these are the deaths that are occurring. I'm going to come to that already. Sorry. Okay. Oops, I think I should do, how do I go back? Oh, don't I wanted you to see that last one. Sorry, it's not going back, but it should. Sorry, can you tell me how to go back? Anyway, don't worry, the same story we're telling. This was a paper published that Lassa fever cases suffer some severe underreporting based on reported facilities. So in fact, even those figures we are getting, they are under whatever. So when it says strengthening surveillance and this, what have we done this period? I dare say, and probably we are worse off than despite better lab facilities, improved and increased human and technical capacity. We have not provided the enabling environment to take full advantage of the strength of our people, of our students. Surveillance continues to suffer severe damage. How much do we spend on surveillance anyway in our region? And how much do we spend on getting our leaders get extra cars to go from the toilet to the office? But let's move on. So there are two other things. They said we should expand One Health and Community Convention and ensure equitable access to vaccines and this thing. So what do I find? On these two recommendations, we are behaving like the 219 Lassa celebrants. We did it and they forgot, and that's the end. We have barely scratched the surface on this issue. One Health remains divided in many of our government institutions and our different countries. We are paying lip service to One Health. Health Ministry will not talk to the Veterinary Ministry on zoonosis, where the Veterinary Ministry is the expert, nor will the Health Ministry talk to Agric, which is the Ministry for Nutrition. And yet, these are the kind of things we're talking about. One Health. What One Health are we talking? Several health. That's what we're going through in many of our different countries. I think it's okay. On the issue of equitable access to vaccines, we saw what happened with COVID vaccine. We don't even have vaccine now. You're talking of equitable access. I think we should stop deceiving ourselves. Anyway, let's move on. Expand this. So we have limited successes on these two issues. Our programs are puppets of donor aid. Take note of that. You know what puppets are? Our programs are puppets of donor aid. We spend what we have on non-essential luxuries instead of the essential things that we need of our life. We have made significant progress, especially, I'm summarizing now from 2019, especially in the area of vaccine clinical trials. But so much still remains to be done even in that. Most of the progress, I keep saying, has come from external donors. Aid is diminishing and is dwindling. Aid could be deadly and could be destructive. You'll be wondering what's wrong with this crazy man. Anyway, it is time for our government and to take the donor responsibility, commit to their promises. These are the issues. That's what I think about AIDS. You may not agree with me. AIDS is a bondage. It is like cancer being treated with Band-Aid. And you can only see our hands in bondage when the aid is coming. Take note of this picture, and that's the life of what we're seeing in our different African countries. But we don't seem to be seeing that problem. Come on. So in terms of infrastructures, it's inadequate cold chain are major challenges. Data gaps, our data, even the data we have, we don't properly analyze them, to make good use of them. And the research we do produce the data we have. Sometimes the research we do doesn't solve the problem. Regulatory framework, many of our regulatory authorities are working on that now. I hope and I pray that they will do what needs to be done. Now, there's something I hear about resource-limited countries. And many of you have written articles in which you say, I studied this in Nigeria, a resource-limited country. How come you deceive yourself? How come you make so much fool of yourself and call yourself the name that you are not? You are not resource-limited. Let's see what happens. I got that from one of the UN agencies, mapping Africa's natural resources. Now, you will see what I mean when I'm talking about. Look at it. Whatever it is you want, it's in Africa. And in terms of ranking, in terms of South Africa is first in gold in terms of which countries have these resources. South Africa is first in gold, is sixth in something. Name the country. Every country in Africa around the coast of the way has crude oil. And look at that, mineral resources, all those issues. So when we come in, and if your country is not there, I'm sure there's no country that is not there anyway in Africa. Sorry, I'm trying to get, that's a better map of resources that we have in our different countries. Name the thing, oil and gas, coal, copper, bauxite, whatever. Somebody has it. There's no country in Africa that doesn't have something. And you say we are resource limited. Are you hearing me? No, I'm just saying, when you talk about resource limitation, you understand what that means. I think this thing wants you to see this map properly. That's why it's not changing. Okay, see, you know what has happened to us in Africa? Africa has become the menu on the table of the expatriate. All of the thing, Zambia copper soup, Guinea bauxite salad, that's the starter for the Europeans. Sweet Nigerian oil, high nuclear uranium, captivating Congolese color. Oh, that's the main dish that they are all eating. Africa is sitting down there. And then dessert, choice Ghana and Ivory Coast cocoa, Zimbabwe tobacco, Uganda coffee, titillating Kenya tea. That's what we, and then at the nightcap, we take Madagascar's herbal tea and Scotching Nigerian Ugogoro. So these are the things. So when you say we are resource limited, we are not. We have only given our resources out to other people to take care of them for us. And that's why we are where we are today. I'm sorry, this thing doesn't seem to like me. Am I getting it? Okay. Now, I'm going to put that in the, oh, sorry. Oh, we can't go back. But that picture there was showing in 1947, India, that was also colonized like us, was begging Canada for penicillin to take care of malaria. In 2022 or 2021, it was Canada that was begging India for COVID vaccine. What did they do? What can't we do? We're all colonized like them. They were colonized like us. So what did India do to beg in 1947 to the one that been begged in 2020? We were colonized 1960, whatever. We are still begging. Even with all that we have, we are still begging. So self-reliance is something that we need to do. Otherwise, we keep getting aid and crumbs. The Bible said it. Those of you who know how to read your Bible. It said aid aids the aider more than the recipient. That's my translation. It didn't say it like that in the Bible. But that's exactly what it means. We are not resource limited. We are only resource wasteful. It is 56 years since we discovered Lassa. We have the resources to control this disease, but I guess I tell you we will not, because I used to get this thing well. Come on. So I'm saying we have the resources to make this and convert Lassa into historical something. We need to create and sustain the enabling environment for a capacity building. I was born, when I was young growing up, they used to talk about capacity building. They built my capacity. They are still asking to build my capacity at this age. But we've forgotten that there's something called capacity retention. It's not going to be done by aid. It's for us to create that enabling environment for all this capacity building to function in our environment, to do the things they need to be done, rather than go out of our different countries. Well, I attended a meeting in which John, one of those donor group, they were celebrating 30 years of helping Africa. And they came up with and said, for the last 30 years, we produced this, and we are still ready to continue to help you. A few of us were put on the panel to discuss, and everybody clapped. Of course, 1,300 people trained. There are 30 years of working with you. And we're still ready. You poor people, whatever you like, we're still ready to help you. And I raised up my hand and I said, thank you for all the efforts we have done. But I have two questions. You've been helping me for 30 years. I've been independent for 60 years. You still want to continue to help me. Something is wrong with you, something is wrong with me, or something is wrong with the aid you are giving me. The time has come for us to think, and then they tell you, think out of the box. Who put you in the box in the first place? I kick the box and I think, and that's the thing we need to do. So stop hearing all these think out of the box. Which box? Who gave you in the box? Who put you there in the first place? It is time to stop before I'm arrested. Thank you very much. But before I go, sorry, one more. I think there's one thing. Okay. Just one more question before you stand up. That's what Seppi told us, what we're going to say. I calculated that with these deaths in 15 countries over a 10-year period, it comes to 22 Lassa fever deaths within a year by vaccine. If we put our money into surveillance, what is our priority? We put our money into surveillance. Sorry, don't be annoyed with me. If I put my money into surveillance and I'm able to do it well, how many lives will I save? I'm not saying don't do vaccine. I'm only asking the question, what should be our priority? And that's what we call thinking with the box thrown out of the way. Now, finally, I want to appreciate WAHO for all the work that you did. I want to especially thank all of you scientists who are working in the field, because we depend on you. Ivory Coast is a special place for me because I have cousins, Professor Umam, my two sisters, Professor Muriel Dozo and Chantal Apokufi. They woke up one day and decided to name part of their building after me. If there's anything that thank you very much.
going to go by my list. So it says here. What if I- December, then I think that's it. I have it. Which representative? I don't know who. I'll just say representative of all. Yeah, so I don't know the names. Yeah, we do. I'll wait. I'll wait before inviting them. Now. Why, sir? Now. I can't start welcoming them with no chairs. Let me see how many on my list. 1, 2, 3, 4, 5, 6, 7. I'll stand. Eight. 1, 6, 8. Lighter. Microphone. Microphone. No, but microphone. So where's microphone? On a besoin d'un microphone. On a besoin. Ok, il peut le mettre sur les chaussures. So I'll have to be very quick. I have to be very quick because there's another panel session after. And Dr. Marie Van Kerkhove has like the beautiful, but just one of the high level executives from the so we don't. Je vais le faire very quickly. Have you got? Let's go to the next one. Les invités? Okay. 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 Je commence. Je commence. Good afternoon. Good afternoon, everybody. Good afternoon, Your Excellencies, distinguished guests. Thank you for staying with us for this high-level ministerial panel session. We've had a few changes in the program, but we're going to invite the guests up on stage. For this session, we will probably have quite a few representatives, as most of our ministers have left. But if left there, they've asked for their representatives to still speak on their behalf. My name is Vivian Hekwazu. I'm the Managing Director of Nigeria Health Watch. And it's a pleasure to welcome you all to this session. You know, today, as we've heard, you know, we all have a shared purpose here in Abidjan today. to reflect, look at strategies, and more importantly, act together on the urgent question of epidemic preparedness in West Africa. We know from our experience that our region is only as strong as our collective response. And Professor Tomori, in his presentation earlier, elaborated and explained the burden that we face in West Africa when it comes to Lassa. This is our collective responsibility. So really, by looking at Lassa fever as a lens into broader epidemic preparedness, regional health security, and resilient health systems, the conversations we're about to have will give us an opportunity to explore how we can build systems that will not only protect against one disease, but prepare us for other health threats. So as much as we spoke about Lassa fever today, we're very aware on the West African continent that we're also faced with the burden of Mpox as we see the reemergence of Ebola in the DRC. So the threats very much still remain. So the panel discussions today will reflect on a few key issues, which is important. And most of these issues will resonate for the rest of the week in many of the side events and sessions you attend. We're going to look at how can we strengthen cross-border surveillance, very importantly, data sharing, so that no outbreak catches us unprepared. This talks about how do we strengthen our surveillance systems across our different borders. What sustainable financing models can secure joint procurement? And how do we ensure that epidemic preparedness is not an add-on, but fully embedded in our universal coverage aspirations? So on that note, I'd like to welcome and invite the guests who will be on this panel session. So first of all, we're supposed to have His Excellency Pierre Dimba. I think we have a representative in Professor Samba. He's coming. Okay, so we have Professor Samba who's coming, representing His Excellency, our host, the Minister for Health. So representing Dr. Aisi, who's the WAHO DG, who is representing, so we have Professor Sombi. Welcome. And we have the Coordinating Minister for Health and Social Welfare for Nigeria. Can we have his representative on stage, please? Okay. Then we're supposed to have the Deputy Minister for Health for Sierra Leone. Do we have a representative from Sierra Leone? Perfect. Thank you so much, sir. Then Dr. Catherine Cooper. Thank you so much for staying for this session. Dr. Catherine Cooper is the Deputy Minister for Health for Liberia. Then we have for the WHO, Dr. Abdulrahman Diallo. I understand Dr. Maria Nkorko, you will be sitting in representing WHO's Regional Director, Dr. Danabi. And last but not least, Dr. Ntuli Kapologwe, the Director General, East Central and South Africa Health Community. Is he in the hall? Fantastic. Okay, let us begin. Let me sit with you. Okay, so let's begin. I think all of you were very engaged when you Professor Tomori, who very eloquently elaborated on the challenge we have ahead. And he mentioned the Lassa Fever Conference in 2019. At that time, it was a reflection of 50 years of Lassa. And he showed how we had had an upsurge in cases. And 50 years later, in 2019, when the first Lassa Fever Conference was hosted in Abuja, similar circumstances with a hall as full as this, engaged scientists, etc. At that stage, we discussed science, we discussed the gaps, and we recognized that Lassa fever, after 50 years, we haven't yet found any vaccine or any cure for it. And it remains, for that reason, very much a huge burden on the West African continent, especially in some of the endemic countries, mentioning Nigeria, Sierra Leone, and Liberia as examples. So really, my question is to the representatives and to the Deputy Minister for Liberia. Looking at these countries, and starting from Nigeria, we have seen WAHO has convened this conference this year, the second Lassa fever conference. But the question I want to ask is, how should ECOWAS countries better strengthen real-time information sharing and joint outbreak response for Lassa fever, given the cross-border spread that we are currently seeing? Because we see Lassa fever as an example, as a test case, how we can strengthen regional surveillance and epidemic preparedness on the West African continent. So my first question is to the representative from Nigeria.
Thank you very much for the that question. Well, I think we are on track because convening this kind of conference is one of the most important way to see that we tackle the menace of Lassa fever in our sub-region. The scientists and also policy makers that are here are going to brainstorm and then come up with recommendation. The problem are known to us, and what we need to do is to put our together and come up with actionable points and find a way of implementing this recommendation from all the governments and individuals and also partners in the sub-region. The capacity is there, though not very strong. We had a very good experience during COVID-19, and that one also gave us a very good lesson so that the resources we have, both human, the equipment, and the infrastructure, should be harnessed. And to do that one, we have to look at the various pillars that need to be strengthened. Among these pillars include the infrastructure, the equipment, especially the laboratories. The laboratories have to be strengthened, equipped, and then the personnel to run these laboratories have to be well-trained. And we have a lot of individual experience in working in these molecular laboratories along the sub-region. So we can harness this individual, we can have a pool of these experts and can be moved to all the centers within the sub-region, not necessarily into one country alone. Doing that one actually give a sense of belonging whereby we strengthen our personality, both in the laboratory and of course, the clinical operations need to be strengthened also. Because as we are trying to control the disease, we also need to see how we can manage those who are infected. And the management of Lassa fever is very, very delicate, whereby if the care is not taken, we are going to have a lot of other infections among the health workers. The community engagement is another thing we should focus, because the community has to be sensitized. This morning we heard about vaccine resistancy. At the end, definitely we are going to talk about vaccine. Very, very important. We are to care of infectious diseases. But the community has to be carried along because they have a very big role to play. Because if you don't carry them along, they may not even accept the vaccine that we are going to promote. So doing that one, actually, we can give them a sense of belonging, also they will support. In terms of financing, we need all of us to bring our resources together in a common basket in the sub-region, whereby the funding can be deployed to areas where there is gap. And this implementation of the funding must not be only to the government alone. We have to look at the individuals. We have a lot of philanthropists in the sub-region, and they can be approached. And I'm sure when they are with a very good advocacy, they will also come in with us. So doing that one actually will mobilize the resources we have in this region. Of course, the partners are there ready. However, partners will not just come until you see how much have you done so that you can support us. Thank you very much.
Brilliant. Thank you so much, Professor Yusuf Bara, Chief PMD, Abu Bakr Tafawa Balewa University in Bauchi. Same question to you, Dr. Cooper, as a Deputy Minister for Health for Liberia, the question really is on cross-border surveillance. So, as ECOWAS countries, how can we better strengthen that real-time information sharing? Because we continue to face these outbreaks, especially as we see for Lassa fever. So how can we strengthen across different countries our cross-border surveillance and information and data sharing?
Thank you, Madam Moderator. It's critical that we strengthen surveillance across our country. We have had the experience of other priorities in our sub-region, and over time, countries have tried to strengthen surveillance at their level. But I think we need to leverage on platforms that have already created our platforms that have been created by sharing Wahoo, WHO, even within the minority countries, there are platforms that have been created, share data, we discuss issues of surveillance, and we strengthen our coordination in those platforms. We also need to do the country-to-country coordination and where countries that are nearby have regular meetings where they discuss share experience. And this will help us have a common ground, common area of sharing information very quickly. There are outbreaks. Additionally, technical capacity so that understand surveillance, how to check cases, how to analyze data, and that go a long way helping us our surveillance in and among countries. We also need to ensure that our diagnostic that once a case is detected at the primary healthcare or the community level, we are quickly able to detect and confirm those cases, and then quickly be able to share that information and generate a response throughout our sub-region where the alerts level will be increased in other countries who have not yet confirmed those cases, so that you are aware and tightening your borders, strengthening your healthcare delivery, ensure that your health workers understand the implication of cases that come to the facility, define a case definition for cases so that within the sub-region, we have a common understanding of what to look for and what those cases are. So overall, I think if we ensure that we are speaking to each other as an ECOWAS region, having discussion about critical and important things at high level, but also at our country level.
Yes, thank you so much for that. And I really appreciate and agree with what you said about, yes, building capacity is critical across the West African countries, but also to really strengthen cross-border surveillance and data sharing, we need to be speaking to each other, having platforms where we can share information, and having platforms where we can also have capacity building across the different countries. Thank you so much for that, Dr. Cooper. Same question to Sierra Leone, as Dr. Cooper elaborated on the need for us to talk to one another. Let me just turn that question a bit on its head. Are we speaking to each other sufficiently across the endemic West African countries, Sierra Leone, Nigeria, Benin, etc., so that we're able to strengthen our real-time information sharing, to ensure that we're strengthening surveillance across our different borders? So, question to representative from Sierra Leone. Thank you so much.
Thank you very much, moderator and colleagues, for having done justice. Yes, indeed, we are speaking to one another. But if I take some steps back, for a country to speak to another country in terms of The key word is real-time data capturing. You need to have a plan in your own. I take the country of Sierra Leone, I know very well. We have a plan for our healthcare. And it's built really on the very firm definition of health by the population. That state of complete physical, mental, and social well, and not the absence of disadvantage. That holistic response to the healthcare delivery system, which captures most of what we are saying, and we call it the life stage. And we are deliberate in doing that to make sure that we have a healthcare plan for our country before you start talking to others. You have to have quality data captured in your country. Then you can talk to other colleagues to also see what can be done. And for us to have quality, sustainable capturing of the data, we are very deliberate in making sure that we get the quality of care in 4 areas: infrastructural development, human resource management, supply chain, drugs, and diagnostic. But data in particular, you need to have the infrastructure in place, fit for purpose building. You need to have sustainable energy. In Sierra Leone, our Minister of Health is green energy. Almost all our health facilities have received solar energy. And when you have sustainable energy in the form of solar, where we have summer all year round in Africa, including Sierra Leone, then you can capture data in real time, all the necessary tools that you have. And when you are able to capture data in real time, the quality is very much improved. We will capture data on paper. Paper-based data capture has been challenging, difficult to transport and difficult to share. But now we are very deliberate in Sierra Leone. We have a digital health system, and our healthcare delivery is really based on renewable energy so that you can generate the data. And when the quality of data is generated, then you can now talk to your colleagues in the neighbors. I'm very happy a few months back, we collaborated a whole lot with the region, and Liberia, the whole Minister of Health, the visited Sierra Leone, and we had good discussion on our digitalization, especially in key area, not only in surveillance also, but key indicators of maternal mortality. Sierra Leone used to have the worst maternal mortality for 2014-20, almost 1,000 per 100,000 lives back. We're able to double down on that by almost 79%. Now we are about at 304 per 100,000 lives back. And we digitalize the whole process to make sure that the 350 to 400,000 pregnancies here are all captured in the situation room we call a breast track. When you digitalize your data, then it becomes comparable, internal and external validity is guaranteed. And that's what we did in Sierra Leone. So now we can speak to our colleagues in the sub-region for what we have. I think that was good for Liberia who visited us. And with that, even with the National Public Health Agency, also that's the fourth arm of the healthcare delivery system, again in Sierra Leone, we have a primary health 80 to 90% of our cases. Secondary and tertiary, in between referral assistant, we have the health security. And our National Public Health Agency speaks very well with the sub-region colleagues in Liberia, Nigeria, etc. So we are very deliberate to make sure that we capture data in real time. Then, with internet, the world is like a global village. So we're able to talk to our colleagues really with digital space. And with that, with the whole Africa now capturing this area, I think we are going to stand very well in sharing data with one another. We collaborate very well and we speak to one another very well.
Thank you so much for that. And it's really good to hear how we've moved away from a paper-based system. I can just remember the situation we had in Nigeria at NCDC when we moved away from paper-based to the SORMAS system that enabled digitalization and the real-time collection of data. And what that enabled us to quickly do is able to get real-time data when we had outbreaks and better response. Having those digital systems across our different African countries, I think is important. So we have common platforms through which we can share respective health data. My next question is to Dr. Sombi, representing the Dr. Aitzi. I have to say congratulations, and I'm sure everybody here agrees, congratulations to WAHO for convening this very important second Lassa International Conference. It's really critical and important that we come together and have these discussions, as was discussed earlier in the ministerial roundtable, that Lassa fever is really our problem, and that was reiterated by Professor Mohammed Ali Pate. So as a follow-up question and looking at cross-border surveillance, given WAHO's unique mandate within ECOWAS, how will you strengthen its role in cross-border surveillance and ensure that the outcomes from this meeting drive sustainable joint action on Lassa fever? Thank you. I'll speak very quickly. Apologies.
Ok. Merci à Diane pour la question. Tout d'abord, je voudrais expliquer parce que pour des contraintes de dernière minute, il n'a pas pu être. Alors, que fait l'OAS? Qu'est-ce que nous essayons de faire pour améliorer donc la place de l'OAS dans tout ce qui est la facilitation, la collaboration et de la surveillance entre les pays? Il faut dire que l'OAS, au niveau du partage des données, depuis 2010, nous avons développé une politique d'information sanitaire régionale. Je crois que mon collègue qui est en charge est dans la salle ici. Et nous avons travaillé avec l'appui de l'Université d'Oslo, ce qui nous a permis aujourd'hui d'avoir une plateforme de HS2 qui permet un partage de données sur les événements épidémiques avec tous les 15 pays de la CEDEAO. Et cela se fait de façon parfois automatique, construit à partir donc de la feuille Excel que l'OMS avait mis à la disposition des pays. Et ce qui aussi est très intéressant dans cette plateforme, les pays ont la capacité d'aller sur la plateforme et voir ce qui se passe autour d'eux. C'est-à-dire à partir de la plateforme, celui du Sierra Leone peut voir au niveau des frontières, par exemple, avec le Libéria, est-ce qu'il y a une zone frontalière du Libéria qui a un problème? S'il y a une zone frontalière qui a un problème, il peut le voir. Donc, ça permet ainsi au pays d'échanger et de partager. L'OAS travaille aussi à accompagner les pays à améliorer donc, la gestion de ces données parce qu'on sait que ce n'est pas facile. Au niveau des pays, on a une équipe chaque année qui a des programmes qui accompagnent les pays, soit pour améliorer, vérifier la qualité des données, améliorer la revue de leurs données et ceci permet donc de faciliter. Ensuite, au niveau de la surveillance transfrontalière, ce que nous avons fait après l'épidémie d'Ebola, on a appris que pour améliorer la surveillance, il faut donner des capacités aux gens qui travaillent au niveau des frontières. Et comme vous pouvez voir, on a fait un travail dans la sous-région. Si vous prenez entre nos pays, il y a beaucoup de zones de passage. Beaucoup de zones de passage existent où il n'y a souvent pas des agents. Mais même là où il y a les agents, la surveillance n'est pas bien organisée. Et un travail a été fait avec notre équipe qui est basée à Abuja pour définir avec les pays quels sont les types de formation pour quel type d'agent au niveau des frontières. Ils ont pu élaborer un certain nombre de curricula de formation. Et comme le travail a été fait avec tous les partenaires, ce qui a été intéressant, aujourd'hui, presque tous les partenaires utilisent des outils de formation, des curricula, pour former aussi bien les agents de santé, mais aussi les non-agents de santé qui travaillent au niveau des frontières, comme l'équipe de la police, de la gendarmerie, de la douane. Donc, ce qui permet donc de mettre tout le monde sur le parfum de l'importance de surveiller les maladies au niveau des frontières. Et je peux dire qu'aujourd'hui, il y a beaucoup de pays qui ont fait cette formation et on voit des changements. Durant le Covid, on a essayé, mes collègues sont encore dans la salle, d'essayer de digitaliser. C'est une plateforme de partage d'informations instantanées. Vous savez, la politique de partage de l'information dans les pays elle est un peu difficile. Chaque pays est un peu normalement souverain sur ses données, mais on a commencé le processus, je pense qu'on n'a pas pu terminer, mais l'équipe est encore en train de travailler. Donc, la logique que nous visons au niveau de l'OAS, c'est d'amener les pays vraiment à continuer à travailler ensemble. Chaque année, on a des réunions avec les acteurs de la surveillance, on a des réunions avec les acteurs, donc tout ce qui est la gestion des données. Donc, voilà ce que nous faisons, ce que nous essayons d'accompagner. Et tout ce qu'on le fait avec tous les autres partenaires. L'OMS est là, je crois qu'on fait nos travaux toujours ensemble. Et avec Africa City, parce que Africa City, c'est avec du personnel qui était dans nos bureaux à Abuja, ce qui fait qu'on a toujours travaillé dans cette vision. Et la vision de l'OAS, c'est qu'on doit travailler regroupés. Parce qu'aucun acteur seul ne peut améliorer la surveillance dans les pays. Mais la grosse question qui reste, et que tous mes collègues le savent, c'est que c'est comment améliorer la surveillance pour faciliter l'alerte. Ça, c'est le gros défi parce que tout ce que nous avons, on utilise souvent ce qu'on appelle la surveillance hebdomadaire. C'est-à-dire, l'OMS a mis en place une politique qui est que chaque semaine, les pays doivent partager les données hebdomadaires d'un certain nombre de maladies à potentiel épidémique définies selon les pays. Mais maintenant, la grosse question qu'on a, quand on analyse ces données, on trouve que souvent, on est toujours à 1 ou 2 semaines de retard. Maintenant, comment partager de façon instantanée les données? Ça, c'est la grosse question. Et je crois que le Nigeria, avec Sormas, avait déjà commencé cette politique. Le Ghana suivait. Et nos équipes étaient en train de voir comment cela peut se faire. Parce que si quelqu'un détecte quelque chose aujourd'hui au nord du Niger, à la frontière Niger-Bénin, et que c'est partagé instantanément, que tout le monde voit, ça facilite. Mais pour le moment, je pense qu'il y a beaucoup à faire à ce niveau. Et nous continuons à travailler à ce niveau. Merci.
Merci beaucoup, and merci beaucoup, Professor Sombi. And thank you for giving us those many examples of how WAHO strengthened capacity, starting with not just building capacity of the frontline workers, but also the police, and also the importance of working with partners, Africa CDC, WHO, but also, as you lastly said, how can we ensure that you have real-time data so that when you're responding, there isn't that delay in response. So thank you for highlighting some of the things that WAHO is absolutely looking to do across the different West African countries. My next question is to Professor Mohamed Samba, representing the Minister for Health for Côte d'Ivoire. I mean, we've heard examples given by Professor Sombi and Dr. Cooper about strengthening surveillance. But just to pivot a bit away from the climate preparedness, but also to an important area, because we look at looking at the national level, how can we ensure that we're not working in these parallel silos that we often do, these vertical programs, just looking at epidemic preparedness? How are we integrating and ensuring that epidemic preparedness is mainstreamed into universal health coverage, the aspiration of most of our countries, and into the national development strategies, so that it's not sidelined and just looked at as a competing fiscal priority? But how do we make sure that our aspirations for UHC and epidemic preparedness are mainstreamed and better integrated?
Merci, Madame, pour la question. Je voudrais excuser la santé qui m'a demandé d'être présent à ce panel. La question sur la surveillance régionale transfrontalière commence d'abord par la surveillance nationale. Il faut que nos pays même aient dans leur sein des systèmes qui soient robustes. Sinon, nous allons partager des informations qui sont fausses, il ne faut pas de panique. La première des choses, avoir des systèmes robustes dans chaque pays. Et je pense que l'OAS et d'autres partenaires nous aident dans ce sens. Je prends par exemple la formation depuis le terrain. Pour moi, c'est un exemple même premièrement, de collaboration, que les gens qui sont formés au niveau régional ou sous-régional, qui permet de trouver des épidémiologistes dans chaque région. En Côte d'Ivoire, on a commencé par être ces personnes formées sur les frontières. Le frontline, c'est ceux qui sont les premiers à avoir. Et ils ont été formés sur les frontières, de sorte à être l'œil de santé pour pouvoir surveiller ce qui se passe. Et ensuite, cela doit se traduire dans un système d'alerte précoce. Parce qu'il y a les données de routine qu'on collecte dans DHS2, mais nous avons en Côte d'Ivoire, nous, un système d'alerte précoce. Qui fait dire que dès qu'il y a un cas qui est un événement indésirable en santé, automatiquement, grâce au téléphone, au SMS, on informe notre institut d'hygiène de santé publique et on fait immédiatement la vérification et l'investigation et ensuite la réponse. C'est par là que cela commence.
À partir du moment où le système national fonctionne, on peut maintenant partager les données avec d'autres pays. Nous avons, par exemple, nous en Côte d'Ivoire, deux exemples à nos deux frontières. On a un exemple qu'on fait avec le Ghana, à Noé et Djibouti. Un autre qu'on fait avec le Libéria. Le premier était sur le cas d'un plan sectoriel de surveillance. Et avec le Ghana, on a mis en place une unité mixte avec les Ghanéens au niveau de la frontière de Noé, qui est le point de passage entre la Côte d'Ivoire et le Ghana, pour surveiller les pathologies qui pourraient éventuellement arriver. Également, on a fait la même chose du côté ouest de notre pays. Mais notez que les deux pays qui nous entourent sont des pays anglophones, que malgré tout, la langue reste une barrière dans notre espace. Même si on ne veut pas le reconnaître de manière formelle, c'est une barrière. Mais nous avons travaillé avec les anglophones du côté Ghana, les anglophones du côté Libéria. C'est pour dire que cela est possible. Mais ça commence d'abord par la formation de qualité des personnes qui sont en front line. Ça permet après aussi d'avoir des données de qualité, parce qu'une analyse de données non qualitative ne sert strictement à rien. Et nous avons aussi à la fin faire en sorte qu'on puisse partager la bonne information au niveau des autres pays. Mais tous nos pays ici envoient leurs données de manière systématique à l'OAS ou à l'OMS lorsqu'il y a un événement désirable ou lorsqu'ils veulent indiquer qu'il y a une épidémie ou une maladie à déclaration obligatoire. Ça, c'est un travail que nous faisons. Dès qu'on confirme par laboratoire que la pathologie indiquée et une maladie à déclaration obligatoire est dans le pays, nous la déclarons à l'OMS, à l'OAS et aussi à Africa. Donc voici un peu les exemples que je peux donner pour la Côte d'Ivoire, mais je reste open pour voir s'il y a d'autres questions.
Merci beaucoup, Professor Samba, showing how this strengthens cross-border surveillance and also strengthening the capacity of frontline health workers as examples in Côte d'Ivoire. My next question is to Dr. Kapolokwe, the East Central Southern Africa Health Community. We began with the critical issue of strengthening cross-border surveillance and information sharing, but we know that across these different African countries, it's not so straightforward. And we know that the issue of financing is, of course, very critical, and how we as a country need to have locally driven solutions that are domestically funded and financed, which is one of the big issues we're discussing during this conference. So from your experience, from your work, what political and financial commitments do you see as essential in the East and Central African health community to help to mobilize the necessary financial commitment for epidemic preparedness, especially diseases like Lassa, etc.?
Thank you very much, and I really appreciate for being invited to this very important conference. We do not have Lassa fever in the East, Central, and Southern Africa. We have some other challenges, but one of the biggest challenges that we're experiencing is around the other viral hemorrhagic fevers, the Marburg, the Ebola is some of the challenges that we're experiencing on the other side. But we are part of the continent Africa, and as you know that Africa is one, so we need to be better prepared for any challenges apart from the Lassa fever, but with the other challenges which can be obtained from the other side of the continent. So with the issue regarding the healthcare financing, this is one of the challenges that most of the countries are experiencing. So we as EXA Health Community, we are advocating for coming up with the regional public health emergency fund that should be somewhere to be able to help the countries whenever they experience any outbreak or any epidemic. So we have started with some conversation with ministries, with the technocrats, and we have established what we call the community of practice to discuss how the framework will look like. And that framework is going to be one of the solutions as far as the challenges of getting the
the finances in responding to the outbreaks and epidemics. That's one. But also, we are thinking of strengthening the international health desks among the member states. We believe that if these desks are responsive, they are well prepared, then they should be able to communicate on time. And I do agree with one of the points that was raised here from Sierra Leone that timely reporting, having quality data is key. Because oftentimes what we are experiencing, especially in our region, one may report an outbreak 2 weeks after it has happened. So we also need to strengthen the community healthcare systems. We need to support the community healthcare workers with the gadgets that needed to report on time. But apart from that, we should also prepare the healthcare workers, especially who are working at the primary healthcare level, because these are the ones who are to encounter even the index cases. So they need to be well prepared for them to be able to respond timely, but also cautiously. So the issue of having the event-based surveillance system is one of our key priorities in the region, and we believe in so doing, then we can be able to address. But the financing part, domestic financing is key, but also having the regional public health emergency fund. In our region, part of the WHO Afro, we record up to 160 emergencies per year. So Lassa is one of them. So we really need to come up with a very good strategy to be able to respond to these emergencies. Thank you.
Thank you so much. Thank you so much for that, Dr. Kapologo. It's almost as if you were sitting on the ministerial roundtable that took place earlier today, because one of the things that was highlighted is, yes, there's huge focus on finding the necessary diagnostics, therapeutics, vaccines. But one thing we need to all acknowledge is none of these things are effective if it's not underpinned by a strong primary healthcare system. You cannot build a house if the foundation is weak. In addition, how do we ensure that community engagement is central to everything we do? We may develop vaccines, but what if the community doesn't want them? So thank you so much for highlighting the importance, very critical importance of community engagement and strengthening those frontline community health workers. And that actually segues quite nicely into the question I have for you, Dr. Maria. As was just mentioned, community engagement is critical, and building trust is very important, community trust. And we saw in May 2005 how 2025, earlier this year, with the pandemic agreement adopted and PABS in its final phase. How can governments, working with WHO, build citizen trust in epidemic preparedness, ensuring transparency and accountability in the responses to diseases like Lassa fever, amongst others, in order to ensure that mistrust does not hinder outbreak control? Thank you.
Thank you very much, and thank you very much for having WHO on the panel today. It's a critical question, and I think is going to grow in importance as time goes on, certainly in the environment that we are acting in now. I first want to acknowledge the regional commitment and what we heard at the ministerial meeting earlier today around the ownership of a problem, a challenge like Lassa, but also using Lassa as an example of a pathogen with epidemic and pandemic potential. We keep learning from these outbreaks, but how do we have that retention of those capacities that have been built? We never start from scratch. And part of that is around community engagement. Outbreaks begin and end in communities, but communities themselves can actually prevent outbreaks from happening in the future. And I think there's two elements to talk about here. One is trust, which I'll come to in just a minute. But regarding Lassa, we know there's a seasonality. And for a pathogen like Lassa, there can be an anticipation for the strengthening of the surveillance, for engaging with communities of where these outbreaks are going to occur, to having the clinical care pathway in place, strong diagnostics, protected health workers, IPC practices, working with our partners in the animal sector as well, we know this is going to happen. So how do we anticipate in terms of the planning and sharing information rapidly? So you talked about the surveillance, and I just wanted to comment on that as well, because it's beyond the person, place, time. It's beyond the numbers. It's looking at the dynamics beyond, what is happening and why we're seeing some of these changes in transmission or whatnot. And in sharing that information across the borders, other countries can be better prepared, not only to engage with the communities, but also through that clinical care pathway and engaging our risk groups. I think the trust issue is being challenged on every front right now. Trust in governments, trust in organizations, whether these are international organizations or regional organizations, trust in science, trust in data, trust in numbers. And I think the collective approach by the region, with support from WHO, with support from WAHO, with support from Africa CDC, that collective voice that you have in communicating what the threat is, communicating what you know, what to do, but also providing communities with options. It's not just about saying there is a risk there. It's about equipping and empowering communities with what they can do to protect themselves and their families. But I do think trust is going to be challenged much more now than it ever has in the future. Just taking experience from COVID, but in the years and in most recent months, the jobs that political leaders, public health leaders have, I think is going to be challenged. So the voice that we have in standing up for each other, communicating collectively about the risk is really quite important. And I do think, if I may, just on the question of financing, I do think part of us, we need to talk about the financing for health differently. We all just went through COVID and everyone's pretending it didn't happen. And we've all gone through that collective trauma. We've gone through Ebola, we're going through Mpox, we're going through avian influenza, but these outbreaks outlive political cycles. So what is the collective interest that we have? We start talking about health as defense. There's always money for defense, always, but not necessarily for health these days. So I think in standing together as a region, West Africa, I think that can help strengthen the work that we do, but it can also help in the trust that we have in the communities where we work.
Thank you. Thank you so much for that. And yes, we all know in this room how trust is being challenged, and how we get past that requires really that collective effort and trusting everything from vaccine mandates to even community, building that trust, and also ensuring that communities have the information from the right sources to make those informed decisions about their health. And it really, yes, it will require collective effort. It will require through institutions like WAHO, NCDC, Africa CDC, all the other multilateral organizations really work collectively to ensure that we are building trust, because otherwise all the work that we're doing in diagnostics, vaccines, therapeutics will come to no use if the communities do not even trust the science that actually inform those interventions and countermeasures. I'm going to just ask a closing question, because I'm very conscious of our time. And I'll just put the same question to all of you. And this is looking forward, looking ahead to 2030 and perhaps even beyond. How do we know that we've succeeded? What key milestones can we say that we can guide and look at regional progress in something like Lassa fever and know that we've made an impact? As Professor Tomori showed us in 2019, when we had the first Lassa fever conference, now we're still seeing upsurge in cases. So if we look forward to, let's say, 2030 and beyond, what key milestones can we say that have guided our regional progress, and we can say we've made advances in actually addressing this issue of Lassa? And let me start at the far left with Dr. Abologwe. Thank you. And then we'll go to you, Maria, and then come this way. Thank you very much.
Yeah, we will realize one of the key indicators when we will be able to respond using our own resources domestically after being mobilized without waiting for someone else to be able to actually come first and then to respond. So one of the indicators is that. But the second one, we are recording more than 160 public emergencies per year. But to see if that goes to a single digit, it's going to be a very good indicator as well. Thank you.
Thank you so much.
Thanks. So there's a number of different indicators I think that we can look at if we think of it from a health perspective, two perspective, one from an R&D standpoint and one from a health perspective. I think if we can address some of these unknowns that we see for Lassa, but also having those research capacities for that next pathogen that emerges, those capacities need to be in region. That data needs to come from region, from science. So you have this incredible conference that's happening here. And it to be the second one for Lassa, we'd like to see more of this and bringing people together to address these unknowns. But when you address an unknown, you have 10 more. So it's just kind of pushing that R&D agenda, not just for medical countermeasures, which we absolutely need, but also to understand the pathogens that we're dealing with themselves. But another major indicator would be around morbidity and mortality. You know, what are we seeing in terms of actually impacting people's lives from a morbidity standpoint and a mortality standpoint, but also looking not only at health, but as an economic indicator. One of the things we certainly saw with COVID and we see from other outbreaks is that it's not just the health impact that has a devastating effect. It's the change in livelihoods, it's the change in lives, it's the businesses that have shut that won't open up again. It's the children who haven't gone back to school and who will never go back to school. So reducing these outbreaks, not only can we measure in reduced morbidity and mortality, but we can also look at the reduced economic impact. We're not going to be able to prevent every outbreak happening, but we can certainly have a much better impact, a much better outcome on the impacts that they may cause.
Thank you for that, Dr. Cooper. I'm borrowing from what Tomori said. Your view, same question. Will we be celebrating or cerebrating by 2030 moving forward?
Well, I agree with the milestone on morbidity and mortality. It will be one of those milestones that we should assess ourselves on. But additionally, we should also assess the health system's ability to detect and to be able to respond and to treat cases with favorable outcome. So to be able to realize that your health system is strong enough to encounter whatever pathogen and still be resilient and still have minimum impact on your community.
Thank you very much. And to you, Prof. Farah.
Thank you. Way forward, I think we should develop a regional program which is sustainable and a program that we can own, because we have a peculiar, as a region that we may not copy other programs that will be as successful as being implemented somewhere. So having this kind of program and also sustaining the program, we should have a milestone to measure and evaluate ourselves to see whether we are winning or we are succeeding. And it's important also to have form of simulation exercises within the region. We should always be ready for any epidemic. Lassa fever is an example. Other epidemics may come. So we should be simulating, response in terms of patient care, in terms of response to laboratory services and community engagement. This will keep us fit to, tackle any epidemic that will come. Thank you.
Thank you.
Thank you very much. I think been very hopeful from what I got from the ministerial roundtable, the new way of working together as a team. Come 2030, we should be to some extent celebrating, because we recognize the need of working together as a team, which will take us far, true to the African proverb. If you want to work fast, you go alone. But if you want to go far, you go as a team. So that teamwork is what is going to make us celebrate in 2030, when we will have appreciably achieved universal health coverage. And in 2030, I'm sure we'll have energized the communities and recognized that pandemics begin and end in the communities. And so we need to have a deeper engagement of the communities, which is what we are doing now in all what we're doing. And also, by that time, we're hoping that by 2032, the Lassa fever vaccine will be ready to roll out. We're going to shorten that time based on what we decided today. That every commitment is we've got full political commitment, which makes it work faster. We've got full community engagement. So I think by 2030, we should be celebrating and keeping ourselves in checks and balances as we go along as a team, especially leveraging on the digital platform with which the world is a global village. Thank you.
Thank you. Samba?
Merci. Je pense que le mot-clé est sorti, c'est la résilience. Il faut que nous soyons capables d'assurer cette résilience. Il faut les étapes, je pense, qui sont importantes, mais ce sont les étapes classiques en cas de riposte. C'est d'abord améliorer notre surveillance par la formation, par la mise à disposition des outils à nos agents de frontières et partout. C'est aussi affiner le diagnostic entre le moment où on détecte, où on pense détecter, où on imprime les cas, et puis le fait qu'on confirme la maladie. Quelquefois, ça met 1 à 2 semaines. D'où, qu'est-ce qu'on fait entre-temps? Est-ce qu'on prend quelle décision? Et c'est après ça qu'on diffuse l'information. Donc, on doit raccourcir les délais entre la détection ou l'identification et la confirmation du cas. Et aussi assurer une réponse qui soit prompte, rapide. Et souvent, nos pays manquent quelquefois de moyens pour assurer cette réponse. Mais personne ne viendra nous aider si ce n'est que nous-mêmes. Donc, nous devons assurer cette riposte. Et on doit aussi assurer une meilleure collaboration avec la santé animale. Parce qu'on se rend compte que 70% de nos pathologies viennent du règne animal. Mais sans une collaboration franche avec le service vétérinaire, le service de santé animale, je pense que si on ne pourra pas. D'où le point essentiel qui est le One Health. Il faut que dans nos pays, on puisse mettre en œuvre réellement le One Health. On puisse comprendre que seul, on ne peut pas, qu'avec la santé animale, nous allons pouvoir trouver des solutions et ensuite pouvoir surveiller à la fois la santé animale, la santé humaine, la santé environnementale. En surveillant la fièvre de Lassa, on surveille toutes les autres fièvres hémorragiques et on surveille aussi la santé de nos populations. Moi, je suis convaincu que nous pouvons y arriver, mais cela nous va demander à nous, pays africains, d'avoir cette capacité de résilience pour faire face à tous les chocs qui nous ont arrivés. Aujourd'hui, nous parlons de Lassa, mais il y aura aussi une petite épidémie de choléra qui va passer par là. Il y aura une épidémie de rougeole qui va y arriver. Et aussi, à la fin, on va avoir un petit Ebola. Donc, c'est pour dire que toutes ces maladies doivent être surveillées par le seul et unique système que nous avons en termes de surveillance, système d'alerte précoce et de riposte.
Merci beaucoup, professeur Samba. Sambi?
Ok, merci. Je pense que pour moi, tout est dans ce que nous sommes en train de dire aujourd'hui ici, c'est la collaboration. Elle doit être multidisciplinaire, multisectorielle. Parce que je crois que ce qu'on a appris de toutes les épidémies, c'est qu'on ne pourra jamais se lâcher. La collaboration, elle doit être multidisciplinaire. Parce qu'il faut que la santé s'ouvre à d'autres secteurs. Il faut qu'on comprenne qu'on doit apprendre des autres. Tant qu'on ne va pas apprendre des autres, on ne va pas changer. Même la surveillance dont on parle. Pour mieux faire une surveillance communautaire, on a besoin des sciences sociales. On a besoin des sciences sociales pour nous donner la compréhension, la perception des communautés et voir comment les engager. Si nous allons seuls, on ne va pas réussir. Deuxième élément de collaboration multisectorielle et disciplinaire important. Parce qu'on doit comprendre que chacun a un rôle à jouer. Aujourd'hui, quand on parle de surveillance, on parle beaucoup de surveillance clinique, mais je me rends compte que la surveillance laboratoire est très importante. Mais malheureusement, souvent on parle beaucoup de surveillance, mais on ne regarde pas le côté laboratoire. Au niveau de l'OAS, nous sommes en train de travailler sur un réseau avec les réseaux des laboratoires. Et je pense qu'on les a mis dans un système qualité, le système SPLITA de l'OMS. On a vu comment les changements Je pense que si on fait la collaboration multidisciplinaire, multisectorielle, moi je crois qu'on va arriver. Et je suis sûr qu'on a les capacités, comme l'a dit le Premier ministre de la Côte d'Ivoire. Si on travaille seul, même au niveau pays, on peut réussir. Mais elle a dit, on sera plus excellent si on travaille avec tout le monde. Je pense que ça, c'est un bon message qu'on doit prendre, promouvoir. Merci.
Thank you so much for coming on that closing remarks. I think you brought it home as well by highlighting that, yes, by 2030 and beyond, we do want to have metrics say we have succeeded, but that's not going to be possible if, as Professor Samba highlighted, we have a multitude of infections to overcome. The importance of collaboration, not just across the different West African countries, but collaboration across the different ministries. We heard Professor Potomori mention we've got environment, we've got agriculture, we've got health. You know, if we really truly want to have that One Health approach, absolutely have to have collaboration. It is not one health lens, not just across our individual countries, but across our collective regional West African countries. So thank you very much to everybody who has stayed, but thank you very much to the panel for your expertise, for your insights, and for really responding and understanding how through cross-border surveillance, financing, building trust in community, when we look forward to 2030, the next conference, if we have one, we can absolutely say that these are things we have learned. We've learned from our lessons, and this is how we have looked to improve outcomes, especially using Lassa fever as an example, how we can strengthen the West African region's ability to respond to outbreaks, which, as we know, can happen at any time and do happen at any time. So once again, thank you so much to the panelists. Thank you to everybody who has stayed with us this evening. I know you've been very patient, and I hope you found the discussions engaging. Just want to join me and thank our distinguished panelists for their time. Thank you.
Oui, oui. Et sans transition aucune, nous allons annoncer la dernière session de ce jour, et la dernière session plénière. Donc, s'il vous plaît, ne quittez pas la salle. C'est juste une session de 30 minutes. Et après cette session, on pourra avoir le cocktail de bienvenue. Ladies and gentlemen, thank you for your patience. We will quickly ask for your indulgence to be with us for the last session of the day. And for the last session, I would like to call on the moderator of the day, which is Mrs. Elsie Ilori. If she's here, she should please join me here for her to announce the next session and call the panelists, please. Hello, please be seated. The next session will not last more than 30 minutes. Already the moderator is here, so she will announce the theme of this session and then call on the panelists to join her on the stage. Thank you so much and enjoy this session.
Thank you. I think I know we are all tired, but we need to listen to this session because it's very important. We are going to talk to, we've just spoken to those that are representing our ministers. Now we want to talk to the technical team and get their input on this. So please, can we please sit down and so that I can call the panelists? So like our team for like our team for the conference, Beyond Borders. So now we're going to look at exploring the practical strategies to operationalize regional cooperation mechanisms for epidemic preparedness and response in West Africa, leveraging on the institutional mandates, the scientific evidence, and political will, while drawing from experiences of past outbreaks, COVID-19, Mpox, Lassa fever, of course, Ebola too. Now, for this panel, we're going to focus. Our focus is going to be to explore the practical pathways to operationalize regional cooperation mechanism across the West of ECOWAS member states, and also reflecting on cross-border collaboration during the Ebola outbreak, COVID, and Mpox. So I'm going to call my panelists right now. I would like to invite Professor Nicholas Mida. Professor Nicholas. Professor Nicholas is a senior research scientist and a former member of UNAIDS, of course, WHO M&A reference group. You're welcome, sir. My next panelist is actually, she was here before representing, but now she's going to be here as herself. So I'm going to invite Dr. Maria van Kakhoff. She's the Director AI, Department of Epidemic and Pandemic Threat Management, Health Emergency Preparedness and Response Program at the WHO. Dr. Maria? Okay, I'll call on the next panelist. Professor Sambi, you were here too before, representing, now you're here at your own capacity as the Director of Public Health and Research at WAHO. You're welcome. I also like to invite Dr. Amadou Sall. Dr. Amadou Sall is the Executive Director of Manufacturing and Supply Chain Division at CEPI. You're welcome. I'm not sure, I think Dr. Maria is also very key. I don't know if someone can help to call her, that she can join us. Okay, thank you. I'll just start with my first question. This question goes to Professor Nicholas. I know we have discussed a lot about coordination the last session,
But I would like to ask you in your own capacity. In the context of Ebola and COVID-19, we've seen fragmented data systems. These systems that delay outbreak responses. From your experience with the WHO M&E reference group, how can West African countries harmonize data collection and analyze frameworks to enable real-time regional decision-making?
Pendant que la modératrice va porter son casque, je salue encore les courageux qui sont dans cette salle pour suivre cette session qui n'est non moins importante. Et je vais, en plus de ce qu'elle a dit, qui est un peu quand j'étais jeune, rajouter les dernières expériences. On a tous été au cœur de l'expérience Ebola, l'expérience de la COVID, à des niveaux assez élevés. Pendant Ebola, on était avec le professeur Sombier, chercheur. Avec COVID, j'étais le conseiller spécial président du Burkina Faso pour toutes les questions en lien avec la santé et autre chose, avant d'avoir été ministre de la Santé. Et donc, c'est dans toutes ces capacités que je vais explorer les questions, la question que vous avez posée. Donc, au niveau de l'épidémie de Covid, on a tous constaté, si vous vous rappelez, 2013-2016, 28 616 cas je parle d'Ebola d'abord, 28 616 cas et 11 310 décès, et un échec patent du partage des données où aucun système ne voulait partager la liste des cas contacts pour faciliter la traçabilité et la détection précoce et la riposte, rendant la riposte assez compliquée. Ensuite, la COVID-19, très peu de leçons tirées. L'Afrique, à peu près 10 millions de cas, 180 000 décès, mais en réalité, et tel que publié par l'Organisation mondiale de la santé, Bureau Afrique, c'était un papier de Dr Kabore Joseph, le système de surveillance en Afrique n'a pu détecter que 1,4% des cas de Covid détectés et partagés, ce qui est inadmissible. Et l'Organisation ouest-africaine de la santé nous donne l'occasion, avec cette conférence, de réfléchir un peu sur ce qu'il faut faire mieux. Parce qu'on ne peut pas continuer comme ça, chacun à protéger ses données comme un trésor, alors que les données partagées permettent de sauver des vies. Et donc, pour répondre à votre question, j'ai pensé, et nous saluons l'arrivée de la représentante de l'OMS, j'ai pensé qu'il fallait qu'on définisse un cadre pour collaborer entre les pays en Afrique de l'Ouest et voire même au-delà. Et cette plateforme idéale qui permettrait de partager les données, pour moi, doit reposer sur 5 piliers. Le premier, c'est bien sûr celui de la gouvernance. Je reviendrai. Le deuxième, c'est celui de l'interopérabilité des systèmes numériques, puisque vous savez que maintenant, chaque pays a son système et c'est difficile de comprendre ce qui s'y passe. Troisième, c'est travailler sur la sécurité, la protection des données, tout en affirmant la souveraineté nationale des données. Quatrième pilier, c'est la collaboration entre les pays sous l'égide de l'OAS à travers un réseau d'excellence des spécialistes des données. Et enfin, le pilier du financement pour penser la viabilité ou la durabilité du système qui sera mis en place. Madame la modératrice me permet, je peux élaborer sur ces 5 projets et ces 5 piliers pour clarifier ma pensée, mais très rapidement. La gouvernance, c'est vraiment là où il faut parler des responsabilités, des grandes orientations que l'OAS va donner, des structures, des instances, des plans d'action, des mécanismes de pilotage, de supervision et de contrôle, voire de redevabilité, et surtout le cadre juridique qui doit être accepté par l'ensemble des pays propriétaires des données, mais qui acceptent sous certaines conditions de les partager. Et donc, c'est là où il faudra mettre un comité de pilotage, un secrétariat technique, un comité des normes, des standards, voire un comité d'éthique et de déontologie. Les données, ça tient à l'intimité parfois, et à des mécanismes qui mettent les gens en confiance quand ils donnent leurs données à un niveau supranational. L'interopérabilité des systèmes numériques, c'est ça un défi très important parce que chaque pays a développé quelque chose et difficile à partager. Et par chance, et l'OMS peut-être reviendra là-dessus, il y a maintenant une norme mondiale depuis 2023, c'est la Health Level 7. Je ne sais pas pourquoi ça s'appelle Health Level 7, elle pourra nous expliquer, qui rend le système de données ouvert et facile à partager. Le langage est compréhensible par l'ensemble des systèmes numériques et facile à partager. Et je pense que cette norme, elle est démocratisée, permettra l'interopérabilité des systèmes numériques d'Afrique de l'Ouest. Et c'est là où il y a aussi une expérience africaine à capitaliser. La BAD, la Banque africaine de développement, dont le siège est à Abidjan, a déjà un système africain de données. Si vous allez sur le site de la BAD, avec tout l'aspect statistique, ils ont mis en place un système, tous les pays africains qui ont des instituts nationaux de statistiques partagent régulièrement leurs données et vous pouvez trouver toutes les données de santé. La seule chose qui manque dans cette base, c'est qu'il n'y a pas de données en rapport avec les situations d'urgence sanitaire. Donc, l'expertise en Afrique existe pour créer un système interopérable. La Commission économique d'Afrique aussi a un programme de leadership statistique qui forme l'ensemble des experts des données. Il y a un leadership féminin des données. Il y a un leadership des jeunes sur les données et il y a toutes les écoles de formation qui rendent l'élévation de la masse critique des statistiques. Donc, je pense que c'est possible. Et aujourd'hui, avec l'intelligence artificielle, il est possible que des agents soient cadencés pour aller, si les systèmes sont opérables, extraire les données nécessaires automatiquement, au lieu de rentrer encore dans des systèmes de dépouillement. La souveraineté nationale des données, c'est vraiment le pilier le plus aigu parce que tout le monde protège ces données comme un trésor et il faut donner confiance à travers la protection des données, à travers la sécurité des données et à travers la redevabilité sur les données qui sont partagées au niveau national. Quatrième pilier, la collaboration. Chaque pays a une direction en charge du système d'information ensemble. Chaque pays a un système de surveillance. Chaque pays a un institut national de santé ou un institut national d'hygiène publique ou un centre des opérations sanitaires et un institut national de statistique. Chaque pays a des partenaires qui soutiennent le système des données. Chaque pays a des universités, des centres de recherche et des instituts de formation. Et l'ensemble constitue l'écosystème qui doit être assis autour de la table pour créer le réseau d'excellence sous l'égide de l'OAS. Et pour terminer, c'est le financement. Et sur la même lancée que le professeur Tomori ce soir, je plaide pour un financement hybride. Il faut que l'Afrique s'assume d'abord avant de convoquer le partenariat. Et il y a énormément de possibilités. Quand je vois nos amis nigérians marcher sur des tapis d'argent, Obi Kubana, vous connaissez tous, c'est insupportable de regarder ça et derrière que l'OAS manque de ressources pour créer un système de données. Madame, c'est insupportable. Quand on a vu le mariage de Davido et l'argent jeté, insupportable derrière de dire qu'il n'y a pas d'argent en Afrique. Et donc, globalement, il faut que l'Afrique s'assume et les partenaires vont accompagner l'Afrique à construire un système de. Voilà à peu près le modèle, l'écosystème harmonisé et intégré des systèmes de données que je propose pour permettre le partage des données, accélère la prévention, qui accélère la détection, qui accélère la riposte. Merci.
Thank you, Prof. I think you've so elaborated a lot, and yes, I can get some keywords: governance, durability, data security. That means trust, and then we have collaboration. Thank you, Prof. That's very elaborate. I'll just quickly go to Dr. Maria. Dr. Maria, I introduced you before you came in, but I'm going to introduce you again. Dr. Maria is the Director, AI, Department of Epidemic and Pandemic Threats Management, Health Emergency and Preparedness and Response Program at the WHO. So, Dr. Maria, I'm going to ask you, initially you were representing WHO, now as you. So now from your global vantage point, what roles should regional economic communities like ECOWAS play in connecting country-level surveillance with global alert system? And how can that coordination be strengthened ahead of the next outbreak? Well, when we say the next outbreak, we always have a, so we can't really say the next outbreak because some countries now we're having outbreaks, some countries now. But while you're doing that, I would also, because I hear you want to leave very soon, so I would also want to hear your last 3 points, key actions in the next 2 years. So while you're giving us the points, just think of your next key actions in the next 2 years that you would want us as the ECOWAS states to do instead of being reactive, but being proactive in the regional outbreak preparedness. So over to you, Dr. Maria.
Thank you. I'm so sorry. We're running out. I didn't realize I was on this panel as well as this panel, so my apology. And thank you very much again for having WHO here. And thank you very much for the question. I think the regional economic Ecowas, there's beyond cooperation, collaboration, regular communication. I think putting money and putting investment infrastructure in the region consistently will be incredibly helpful. We've heard about this across many different aspects, whether we're talking about road systems or whether we're talking about data systems, whether we're talking about cold chain, but having that infrastructure in place across the region. The whole point, I understand, of ECOWAS is, these borders that you have to be able to have trade moving across. That includes people as well. So if you're looking at surveillance and you're looking at border surveillance, in many ways, there are no borders, right? We hear over and over and over again that pathogens affect borders, and of course they don't. So how do we make sure that as a regional entity that you're protecting the health of people, but you're protecting the economies? Because without the economies and without these businesses thriving, families will suffer many other challenges, not just the disease itself. Of course, we saw that with COVID, but we saw other diseases. So another way in which, beyond the infrastructure, looking at some complementary policies across the different region so that countries are communicating with each other about the threats that you face, but in identifying patients and cases, what do you do with that information? What do you do in terms of protecting not only people and their families and their contacts, but also the livelihoods of these individuals of moving goods across the border that are really critical for healthcare systems, are good for food systems, et cetera. So those complementary policies discussing amongst the countries themselves, I think would be quite helpful. We saw a lot of challenges with that with COVID. We all were looking at the same data. We knew what needed to be done in terms of preventing onward transmission, but the policies were very, very different across borders, and especially when borders are porous, having those complementary policies is really important. I think also, I mentioned this in the last panel, anticipation. So there's seasonality with Lassa. For the next emerging pathogen, we will not have that foresight. We know another epidemic and pandemic will happen. We just don't know where it will start, when it will start. We don't know which pathogen it will be. We can anticipate what types of pathogens they might be. But for diseases like Lassa, there is a seasonality. So anticipation of those outbreaks and having the systems in place to be agile, to scale up, scale down is really important. And regional entities support that. So I think, there's a lot that can be done, but we're building on past experiences. We hear comments about, learning from past experience, learning from past outbreaks, but yet many times we seem to be starting from scratch. So if we look at what we want to see, these critical things in the ministerial meeting this afternoon, what I really appreciated, and Amadou, my short friend sitting next to me, talked about ownership. There was a lot of discussion about financing, and many of the countries in there said, well, we should be financing this themselves, that national ownership. In addition to looking for resources outside of the region, that national ownership is really critical. I think the commitment, not only from a financial, an economic point of view, but also from a political point of view, I think beyond health ministers to one another, getting that heads of state political buy-in, which of course transcends different election cycles. So having that political support will support ministers in actually achieving what they need to do. Having commitment to the technical expertise, and that starts in the region. It's not about flying in to provide that, but actually the experience of the countries themselves and providing that technical leadership, and also commitment to human resources. So building those capacities, maintaining those capacities within the region, having that human capacity and knowledge base within the region, and we're seeing that. It just needs to be sustained. And then lastly, I'll just end with, commenting around health. So we have seen massive shift in priorities of countries. Certainly with COVID, there were billions provided, but pulling from other resources, of course. But there's always money for defense. If we start speaking about, we talked about global health security or global security or health security, but thinking about health as defense, we've seen governments literally brought to their knees, economies brought to their knees, families completely destroyed because of outbreaks, whether we're talking about a community or nation. But thinking about health as defense and that shift in that mindset could potentially help raise those resources in a much more sustainable way. And there's a lot happening at the national, the regional, and the global levels with the pandemic fund, but also here in itself. But to have the commitment from countries, not just asking for charity, because you're not asking for charity, it's about how do we own the responsibility of the problem and how do we own the solution.
Thank you. That's really appreciate that. You really touched a lot. And I think you just talked about investment in infrastructure, which is very, very important. Investment in infrastructure, sustainable infrastructure, because that is very key. And then we talked about, complementary policies. That is one area that we are very weak in, because each country, they have their policies, and we do not have policies that can come together and help the region. So that's one key area I'm looking at. And then we'll need to own it. Ownership is very key. We've been talking about ownership, but like you said, political commitment is one of the key areas that will help us to own it. And once we have the political will, I think, because the technical team do their work, they're committed, but it's at that top level that we really need to do a lot of advocacy, and we need to educate them on what is expected of them. So thank you, Maria. Really appreciate it. Yeah. So I'll go to Professor Sambi. Well, at home, and it's the region. So I really want to touch on the simulation. WAHO supported joint simulation exercises and pooled procurement during COVID-19. In your view, which of these models should be scaled or institutionalized to improve future cross-border epidemic response?
OK, merci beaucoup. La question sur les achats groupés, je pense que l'OAS, c'est une belle expérience. Docteur Brito est dans la salle ici. Je crois qu'il a été un des moteurs au niveau de l'OAS. Alors, je pense que ça a été une très belle expérience. Même s'il y a eu des difficultés, mais ça a été une très belle expérience parce que ça a permis, pour une fois, au niveau régional, après une réunion ministérielle, il faut se dire que l'OAS, pour arriver à ça, a organisé le 14 février 2000 une réunion ministérielle juste au début du Covid, quand nous n'avions pas encore des cas, pour voir qu'est-ce que l'OAS devrait faire. Un des objectifs que les ministres avaient assigné à l'OAS, c'était de pouvoir travailler à acquérir du matériel et dans les médicaments. Alors, revenu de cette réunion, un travail interne a été fait pour revoir le budget de l'OAS. On était en début d'année, il fallait revoir le budget sur comment dégager des fonds au niveau d'activités jugées pas nécessaires. Ensuite, on avait des projets. Je crois qu'on a travaillé avec tous les responsables des projets qui finançaient l'OAS pour voir comment on pouvait utiliser une partie de leurs fonds pour acquérir aussi bien du matériel qu'un certain nombre de besoins pour le pays. Une fois que cela a été fait, l'OAS a travaillé avec le système des Nations Unies, le bureau UNFPA du Nigeria qui a permis de faire des commandes. Mais avant cela, je crois que je suis content qu'Amadou soit là parce que quand Covid a commencé, et c'est une expérience après, je voudrais vraiment féliciter Amadou pour ça. Amadou était le directeur de l'Institut Pasteur de Dakar. Il fallait trouver des réactifs pour les pays. L'OAS ne pouvait pas payer les réactifs. On s'est retourné vers Pasteur, qui a trouvé rapidement les réactifs et qui a permis de le mettre à la disposition des pays. Et immédiatement, un système de suivi a été fait avec les pays pour voir le niveau de stock, pour éviter donc des ruptures de stock dans les pays. Ça a été quelque chose, je le dis toujours à mon collègue Sou, j'ai dit c'est l'une des belles expériences que j'ai vues à l'OAS qui n'a pas voulu documenter. Parce que de mars jusqu'en fin juin, aucun des pays de la CEDEAO n'a été en rupture de stock de réactifs. Pas parce qu'on avait beaucoup d'argent, mais parce que tous les matins, Dr Sow faisait le point avec tous les pays. Et quand un pays n'avait pas, un pays pouvait suppléer. Donc ça, c'était une belle expérience. Alors, pour les achats groupés, quand on a pu faire l'achat, on a acheté les produits, c'est là aussi un élément de leadership qu'il faut voir. Parce qu'à la CEDEAO, on avait appris, après Ebola, qu'il faut toujours engager les chefs d'État pour la coordination. Et à ce moment, pour ce qui était de Covid, c'est le président du Nigeria qui était le coordinateur des chefs d'État. Quand on a fait la commande groupée et que le matériel est arrivé au Nigeria, toutes les frontières étaient fermées. Pour le déployer, c'est les forces armées nigérianes qui ont été mis à la disposition de l'OAS et les produits ont été déployés dans les pays. Il y a des pays comme le Ghana ont envoyé leur avion à les récupérer. Donc, ça montre qu'il est possible de faire un achat groupé dans la région. Et l'OAS a continué, on a développé actuellement un document sur la politique des achats groupés. À l'Assemblée des ministres de cette année, cette vision a été partagée et les ministres ont soutenu qu'on puisse le commencer avec un certain nombre de produits, notamment les produits rares, qu'il est difficile pour un pays de commander, mais voir comment les pays peuvent se regrouper pour pouvoir faire la commande groupée. Donc, l'OAS a pris quoi? Je me rappelle qu'une des évaluations faites par un expert nous a montré que si on avait été très vigilant dans la commande, on aurait pu faire livrer directement les pays sans passer par le regroupé. Donc, c'est des leçons qu'on a prises et une équipe de l'OAS actuellement travaille sur ce domaine. Je pense que pour moi, ça a été une des belles expériences. Le professeur Okole est là. Lui-même était directeur général de l'OAS. Il a contribué à aller dans les pays pour remettre les produits. Alors, l'autre expérience que nous avons faite, que je trouve quand même qu'on doit le dire, parce que l'OAS travaille beaucoup avec l'Institut Pasteur de Dakar. Et on a une convention aujourd'hui avec l'Institut Pasteur de Dakar qui fait qu'on n'a plus besoin d'attendre comme avant. Quand on va avoir une épidémie, si on a besoin de pasteurs, d'aller en appel des projets, tout. Et je crois qu'Amadou a signé ça avant de partir. Qui fait qu'aujourd'hui, dès qu'il y a un problème de santé urgent dans la région et que les pays n'ont pas de capacité de laboratoire, on peut se tourner vers Pasteur qui nous aide, un, à former rapidement les pays, deux, à trouver les kits pour qu'ils soient et les mettre à la disposition des pays. On l'a fait avec Ebola, on l'a fait avec Marburg, on l'a fait avec Mpox 2 fois. Et pour moi, voilà des mécanismes qui sont très importants qu'on doit chercher à pérenniser dans la région parce que c'est ce qui permet de très vite rendre disponible tout ce qui est nécessaire pour détecter très tôt et permettre donc la prise en charge. Donc voilà les expériences que nous avons faites et c'est des expériences que l'OAS est en train de travailler à les consolider et je pense que aujourd'hui, tous ceux qui travaillent à l'OAS au niveau des pays, pensent que on a appris des faiblesses et un des éléments que vous avez dit, que Marie a dit tout de suite, c'est avoir des textes régionaux complémentaires. Parce qu'on s'est rendu compte, quand vous devez envoyer des produits dans les pays, pour la réception dans les pays, c'est autre chose. Ça nécessite des textes supplémentaires, ça nécessite un certain nombre de décisions au niveau des pays, un certain nombre de textes qui font que probablement, si on a des textes complémentaires à ce niveau, ça peut permettre de faciliter très vite. Dès qu'il y a un produit au niveau régional, le produit est déployé, on n'a pas besoin de mettre tout le système ensemble et faciliter. Donc ça, je pense qu'au niveau régional, et je vais terminer par quelque chose quand même, qui est que nos chefs d'État commencent à comprendre. Avec Covid, l'OAS a pu organiser 8 réunions ministérielles. 8 réunions ministérielles presque tous les trimestres, parfois même plus, et 3 réunions des chefs d'État. Et la dernière réunion des chefs d'État, la réunion des chefs d'État de janvier 2021, les chefs d'État se sont engagés à mettre en place dans la région un fonds renouvelable pour les vaccins, pour l'acquisition des vaccins. Et je pense que si ce fonds arrivait à avoir le jour, avec une contribution, parce qu'on a un fonds de développement on a une banque de développement de la CEDEAO, si cette banque prend le devant et arrive à mobiliser ce fonds et à le mettre à la disposition, je pense que ça, c'est un très bon acquis qui va permettre à la région de pouvoir avancer. Merci.
Thank you. Thank you so much. I think you've really touched on a lot of, the experience from the COVID outbreak and where you coordinated, especially with the logistics. And I think that is one good thing that, happened within the West African region. And I am so proud to be associated with brother here, with the Institute Pasteur in Dakar. I think these are stories that we need to bring out and to tell the world that we have the capacity to do that. We're not looking for aid, but we just want to build our capacity to be able to do more. And I think that is one very good strength. So we need to bring out our strengths and showcase our strengths, and let also our policymakers put in something into those areas so that it help us to grow instead of waiting for people to come and give us aid, just like Professor Tomori said. We don't need aid, but we need to build our capacity. So thank you for that. I think we need to give him a round of applause for that, because it's something that is good that has come out of the COVID outbreak. Thank you. And I would also like to, Dr. Amadou, yes, I'll go to you now. I know you joined the CEPI team recently, and I'm just going to ask a question. On the 100 days mission, that prioritizes rapid vaccine development, given your experience, this from the Institute Pasteur, and your experience with CEPI, what will it take for West Africa to be a key node in the global vaccine R&D and manufacturing? It's one very sore area for us. We need Africa, West Africa, to be part of that manufacturing group. So what?
Thank you very much. Merci beaucoup, Madame la Présidente. Permettez-moi d'abord de saluer et de dire tout le plaisir que j'ai de siéger à côté du professeur Sombier et du professeur Mela, avec qui j'ai eu l'occasion, comme vous voulez, d'avoir de très belles expériences dans les épidémies. Concernant votre question sur la mission des 100 jours, pour ceux d'entre nous qui ne sont pas très familiers avec cette mission, je voudrais juste dire que, en gros, en quoi consiste 100 jours? Ça veut dire que ce qu'on voudrait, dans le cas des pandémies, d'avoir la capacité de pouvoir en 100 jours, donc un peu plus de 3 mois, d'avoir un vaccin qui puisse avoir une autorisation d'urgence et qui puisse être dans les 100 prochains jours suivants produit en quantité suffisante. Donc, cette réflexion vient de ce que les modélisateurs ont appris de la COVID en disant, on a eu le vaccin après 1 an. Si nous l'avions eu en 3 mois, quel aurait été l'impact? Et de dire peut-être on aurait sauvé plus de 8 millions d'infections. Et donc, Cela devient un objectif et une mission. CEPI s'est fixé, qui a été encouragé et cautionné par le G20. Il y a toute une dynamique politique et c'est un objectif extrêmement important qui est porté par. Si on arrive à faire les vaccins en 3 mois, ça peut vraiment nous aider lors des futures pandémies. Alors, c'est un objectif qui est extrêmement ambitieux, mais qui n'est pas infaisable. Je vais donner un exemple. Actualité oblige, on est en train de parler de Lassa par rapport au travail qui est fait entre CEPI, ou les équipes, l'OMS. Comment on va vers ça et d'être un peu plus large sur ce qu'on pourrait faire en plus de ça pour arriver à cet objectif dans les prochaines années. Alors, je vais juste parler de l'expérience Lassa. Aujourd'hui, qu'est-ce qui se passe dans CEPI a financé avec IAV et d'autres partenaires 3 vaccins qui sont aujourd'hui en train d'être développés. Le plus avancé est le vaccin qui est développé par le International Aid Vaccine Initiative, qu'on appelle IAV. Et ce vaccin est dans un niveau de phase 2A pour être justement testé, pour montrer qu'il est pur, pour montrer qu'il a de l'immunogénicité et pour montrer que c'est un vaccin de qualité. Et pour faire cela, il y a tout un travail qui est en train d'être fait. C'est un vaccin qui est testé entre le Nigeria, Sierra Leone, le Ghana. Et c'est un vaccin aussi qui, en même temps, permet de bâtir des capacités. Ça, c'est pour la partie recherche et développement. Et bien évidemment, IAVI est supporté par CEPI, un nombre de partenaires. De la même manière, CEPI soutient IAVI, soutient 2 autres vaccins. Le but de tout cela, c'est de dire que si on a plusieurs candidats, le premier qui arrive va nous permettre assez rapidement de bâtir des capacités. Mais au-delà de ces capacités pour le Lassa, on puisse faire plus que des capacités pour d'autres vaccins. Et donc, ça veut dire quoi? Ça veut dire qu'au-delà de la capacité à faire de la recherche, en même temps, il est bâti tout ce qui est capacité en réglementation. Et donc, c'est un travail qui se fait avec Avaref, mais qui, bien évidemment, sera étendu à AMA et aux autres. En même temps, CEPI finance l'Institut Pasteur de Dakar, qui a signé un accord avec IAVI pour produire ce vaccin au niveau de la région. Et donc, ça veut dire quoi? Ça veut dire qu'on va avoir non seulement des capacités de recherche et développement dans lesquelles vont participer toute une série d'institutions au niveau sous la Gambie avec le Noguchi au Ghana, NIV au Ghana, le Nigeria, Irua, etc., Kenema. Et l'ensemble de ces institutions vont à travers ce projet se renforcer. Et ensuite, on va avoir un producteur local qui va prendre le relais là-dessus en transférant la technologie. Et on va avoir nos autorités de réglementation, le Ghana qui est niveau 3, le Nigeria, NAFCAR, niveau 3, avoir tout ce qui concerne les fondations pour bâtir un système qui va permettre d'être prêt pour les prochains. Et donc, ce travail de construction de capacités qui vont servir de base vont nous permettre d'être de plus en plus efficaces pour développer. Si demain, on a un vaccin Marburg ou un vaccin Rift Valley, il peut utiliser les capacités qui ont été bâties pour Lassa. Et grâce à ça, l'Institut Pasteur de Dakar a une capacité de faire la production de Lassa après l'avoir transféré. Une technologie similaire peut permettre d'aller plus. Donc, pour arriver sur les 100 ans, il s'agit de travailler avec les différents centres, les différentes capacités, les instances de réglementation et les institutions sous-régionales sous la coordination de l'Afrique de l'OAO pour dire que dès qu'on a une épidémie, activons ce système qui existe déjà. À partir de cet exemple de Lassa, qu'est-ce qu'il faut dire? Il faut dire que, bien évidemment, cet exemple va permettre de bâtir des fondations, comme je disais, mais il y a au moins 3 choses sur lesquelles il faut se focaliser pour que ce travail soit systématique. La première chose, c'est le volet réglementaire. Quand on va aller vite, souvent on se rend compte que les autorités réglementaires qui sont ce qu'on appelle doorkeepers. Et ce qui a été bien au niveau de la COVID et qui a beaucoup aidé, c'est que la réglementation a été engagée suffisamment tôt pour ne pas avoir à gérer les problèmes. Donc ce premier problème est très important et de ce point de vue-là, l'Afrique de l'Ouest a quand même pas mal d'avance. Il y a tout un travail qui est déjà fait. Mais je sais que dans les diagnostics, il y a même un seul dossier qui est fait et qui peut être utilisé pour tous les différents. Donc ce travail d'harmonisation du point de vue réglementaire qui a déjà été commencé avec la BRF, c'est un travail qui est extrêmement important parce qu'il permet d'aller vite et en faisant un travail dans un pays, on en profite. Le professeur Sombier parlait tout à l'heure d'une expérience qu'on en a eue. On en a eu une très belle dans le domaine du diagnostic. L'inspecteur de Dakar avait mis en place des tests de diagnostic qui ont été validés par le Ghana et qui ont pu être distribués dans les 15 pays grâce à l'OAS, qui avait déjà mis en place. C'est la deuxième chose, je pense, au-delà de l'aspect réglementaire, qu'il faut avoir en tête. Il faut des capacités de production. Et ces capacités de production, on a beaucoup de chance actuellement. Les technologies ont beaucoup évolué, les investissements plus limités. Mais le fait de soutenir des capacités de production au niveau sous-régional va permettre que l'on puisse les activer très rapidement. Et typiquement, CEPI investit au niveau de l'Institut Pasteur de Dakar toute une infrastructure, des équipements qui vont permettre que Dakar puisse être opérationnel. De la même manière, il y a des investissements qui sont faits au Ghana et dans d'autres pays pour permettre ça. Donc la capacité de production, elle est vraiment essentielle. La troisième chose qui est importante, c'est la volonté politique et le fait d'avoir des marchés. Si aujourd'hui, le pays s'engage à travers des vaccins comme de Lassa, la chef de la vallée de Rue, à les acheter, ça permet aux producteurs de faire les investissements, au secteur privé de s'impliquer, et sur cette base, d'avoir des capacités qui peuvent être déclenchées si on a une pandémie, pour que dès que le pathogène est identifié, soit pour le vaccin dont on parle, qui est le plus difficile, aussi pour le diagnostic, pour le traitement, on a une opportunité d'aller vite en capitalisant sur les expertises locales et le fait que ces différents groupes peuvent travailler. Ça fait une très, très belle plateforme. Et cette plateforme, elle peut être utilisée pour mobiliser des ressources, pour mobiliser de la réglementation, pour mobiliser des capacités et pour faire de l'échange. Dernier point qui me paraît important, c'est que l'exemple de Lassa, il est simple, mais il montre ce qu'on peut faire quand on travaille ensemble. Et cette capacité à avoir une certaine solidarité, c'est la discussion qu'on a eue un peu plus tôt aujourd'hui, où les pays, dont on dit qu'ils vont se mobiliser pour amener ce vaccin à développer à un niveau qui peut être fait. Bien sûr, ça va prendre des années cette fois-ci, mais une fois que le mécanisme est rodé, ça peut aller jusqu'à descendre à 3 mois. Ça peut paraître utopique aujourd'hui, mais je pense que c'est quelque chose auquel on peut aller. Merci, Madame.
Thank you. Wow, that's, from all that you have said, I think that's statements Dr. Maria said. Complementary policy is very key. So if the regions, the countries, the West African region can have this complementary policy, in terms of regulation, we'll be able to complement each other. I mean, production capacity, of course, when the policies are thinking, we'll be able to do that. And then, of course, the political will, which we are seeing now. I think WAHO is doing a great job in that area, bringing the ministers together, bringing even the heads of states together to understand why they must key into their health security. And that's very key. Thank you very much. I really appreciate it. So on a final note, I would just like to ask you all to reflect on a wish list of 3 key actions that must be taken in the next 2 years. Now, we're not going to talk about in the next 5 years. We want it as early as possible. We're saying 2 years. If left to me, I'll say in the next 1 or 6 months. I know it's not possible. So let's give ourselves some, time to work out, and then say in the next 2 years to move from being reactive to proactive within the region. Just 3 last words. Key wish from the 3 of you. So I'll start from Dr. Ahmad.
On a beaucoup parlé de l'expertise qui existe. On a une notion à ces pays qu'on est en train de discuter, qu'on a déjà essayé avec des pays c'est de faire des exercices sur les 100 jours. Ça veut dire on va faire une préparation comme si on voulait développer, prendre une action rapidement pour aller sur les 100 jours. Et en faisant ce type d'exercice, je veux dire sous forme d'une simulation, on peut identifier là où on a des faiblesses et les renforcer. Et quand on fait cela, on peut, quand un vaccin est développé ou actuellement pré-développé jusqu'à un certain niveau, l'utiliser dans une épidémie pour justement finaliser son développement. Ça s'est passé l'année dernière au Rwanda, où grâce à l'appui dans ce type d'exercice, très vite, le Rwanda a pu lancer, quand il y a eu l'épidémie de Marburg, avec un vaccin, il existait un vaccin Sabine, un essai clinique qui a permis de démarrer rapidement en 9 jours. Et ça, c'est le genre d'exercice qui, à mon avis, est très important à faire. Quand les pays se mettent ensemble, là, c'est à l'échelle d'un pays, mais faire des exercices pour comprendre où sont les failles, pour pouvoir justement combler. Deuxième chose qui me paraît importante, je vous ai parlé tout à l'heure de l'exemple de Lassa, c'est quelque chose sur lequel nous travaillons avec les pays pour mettre en place un programme de développement qui est commun. Quand je dis qu'il est commun, c'est que les essais cliniques vont se faire au Nigeria, au Libéria, la production va être préparée à Dakar, la Gambie va aider dans les essais cliniques. Nous allons, et Waho va coordonner, et nous allons ensemble faire le développement, recherche et des finances. Ça, c'est le genre d'expérience qui fait qu'on passe d'un travail théorique à quelque chose de concrètement très pratique. Et la dernière chose, je pense qu'on a parlé de la volonté des chefs d'État. Ils peuvent aller très, très vite sur comment on fait circuler les prélèvements, comment on va très, très vite dans l'échange de connaissances et d'expertise. Et aussi, surtout, faciliter l'implication du secteur privé. Dans le secteur privé, si l'État s'engage à acheter produits, et si l'État fait de l'incitation fiscale, ça permet très vite d'aller. Donc voilà les 3 actions que j'aurais recommandées, Madame la Présidente. Merci.
OK. Je pense qu'Amadou a donné les 3 points clés. Peut-être que je vais ajouter aussi quelque chose. Moi, je pense qu'il faut qu'on continue à croire en nous, qu'on peut. Et moi, c'est ce que je vois. Il faut maintenir donc, cette collaboration et croire qu'on peut arriver. Parce que si nous ne croyons pas, ça va être difficile. Et ça, c'est, je pense que ce que j'ai entendu aujourd'hui, la réunion ministérielle, nous montre les possibilités. Le deuxième point aussi, il faut continuer à former. Je pense que c'est là où je pense qu'il faudra qu'on engage nos universités. Parce que j'ai fait une visite à Cuba. Et quand je suis revenu, pour tout ce qui est de la production, médicaments, vaccins, je pense qu'il faut qu'on revoie nos universités, qu'on les engage dans la formation du personnel nécessaire. On ne pourrait pas faire des médicaments, on ne pourrait pas faire les transferts de technologie si on n'a pas un certain nombre de personnes qualifiées, comme des chimistes, comme des spécialistes, comme des gens qui connaissent un peu tout ce qui est la biotechnologie. Et je pense que là, il faut engager nos universités à ce niveau. Et moi, je vais m'arrêter là. Merci.
Merci, c'est une très bonne transition. Je vais donc inviter l'OAS et professeur Sombier à l'Université Joseph Kizerbo de Ouagadougou, où je crois que c'est le 20 septembre, il y a l'inauguration du centre d'excellence africain financé par la Banque mondiale sur la science des médicaments, qui prépare les acteurs, les compétences pour la production et la bonne utilisation des médicaments en Afrique. Et donc, invité spécial de l'Université Joseph Kizerbo. Maintenant, pour répondre à votre question, le centre s'appelle le CAC Forum. Professeur Semde Rasmani, est le directeur. Pour répondre à votre question, l'action urgente, et pour voler quelques mots de Amadou, les 100 premiers jours, à partir de cette conférence, l'OAS doit développer une note conceptuelle sur le système harmonisé et intégré des données de santé en Afrique de l'Ouest et solliciter les ministres de la Santé pour avoir l'autorisation de déployer ce système. J'ai donné le cadre en 5 piliers. Inspirez-vous de ça. Je vous remercie.
Thank you. Thank you, thank you, thank you. Yes. I think we've heard from the mouth of the technocrats, not the horse's mouth. Don't want to put horses. No, from the technocrats. Those that are doing the work, those that know it, and then they know what the future wants to be like. So thank you so much. We really appreciate it. And we're going to follow up with all these your key points and make sure that WAHO has a lot of work to do coordinating the country. And the countries are ready to work with WAHO. So WAHO, over to you. I know you can do it. Thank you so much. And thank you everyone for attending this last meeting. And want to appreciate everyone for staying behind. I know it's been a long day. We're all tired, but I think gained a lot from this. Thank you.